Hi, lovely good morning, all of you. I hope the night was so perfect. You would have had a nice sleep and you are keeping yourself safe, sound, and strong. So, my dear lovely friends, my dear lovely doctors, we were talking something about gradual arterial obstruction. So, let us quickly have a recap of what we did yesterday. We were talking about that how gradually some atheromatous plaque can form and create traffic jam situation in the artery. Let us revisit that particular area and let us try to understand what all we were discussing yesterday. So we talked about this gradual arterial obstruction. Most common cause is atherosclerosis, where the atheromatous plaque gets deposited here and creates some sort of traffic jam type of situation, because of which definitely the lumen here would be getting slightly narrowed. So probably the supply to the distal part may not be proper, and then patient may present with some ischemic symptoms. So my dear friends, how the story actually starts in this gradual arterial obstruction. So in this arterial obstruction beta, initially how the story starts, the patient at rest does not have any kind of problems, but it is at the time of exercise, when the patient is exercising, at that point of time, the patient may experience pain in that part of the lower limb where the demand is maximum. Like when somebody is walking, the most bulky area is the calf. So calf muscles would be requiring more amount of oxygen. So the patient start experiencing pain in the calf on walking a certain distance. Initially, this calf pain improve with further walking because of washout of substance P, P for Papa, right? Gradually, the patient experiences this calf pain, but he can still continue to walk with pain. And gradually, the pain may become so severe that he experiences pain in the calf on walking. But now, because the pain is so severe, he cannot walk any further, has to take rest. Gradually, if the obstruction is increasing, the patient may start experiencing pain even at rest. And when we say at rest, then if there is a traffic jam somewhere here, it will be the most distal part which will be experiencing the pain. So rest pain is felt in the foot. Gradually, if the obstruction increases, this part will become cold, numb, paresthesias, pre-gangrene, and gangrenous changes will be seen. The Boyd's grading of intermittent claudication, my dear friends, yes, quickly. Calf pain on walking, which improves with further walking, that is Boyd 1. Calf pain on walking, where the patient continue to walk with pain, that is Boyd 2. And calf pain on walking, where the patient has to take rest, this is Boyd 3. And Boyd 4 is rest pain. So, a patient of peripheral vascular disease, that means a gradual arterial obstruction patient, can present to us at any of these stages. My dear lovely doctors, when you would be practicing in February 23, you would be seeing these type of patients, right? What you will be wearing in February 23? Yes, that white coat and the stethoscope. So, how to approach these type of patients? Very simple. We have to examine the different pulses. So we can examine the femoral, we can examine the popliteal, we can examine the anterior tibial, posterior tibial, and the dorsal pedis. Femoral, we can examine 2 centimeter below the mid-inguinal point here. Popliteal is palpated from behind in the popliteal fossa. It is the most difficult pulse to feel because there is no bony prominence here and it is deep. The anterior tibial is palpated at the ankle next to the tendon of extensor hallucis longus. The posterior tibial is palpated between the posterior border of medial malleolus and the Achilles tendon, best felt at the inversion of foot, and dorsal pedis is palpated in the proximal half of the first metatarsal space. Obviously, distal to the obstruction, the pulses will be low volume or feeble or absent, but proximal to the obstruction, the pulse may be high volume or normal. So just by knowing where is the high volume and where is the low volume, you can clinically try to make out what is the site of obstruction. Sometimes, if the patient has developed collaterals, you may find a disappearing pulse. Whenever there is an obstruction in the artery and you do the auscultation proximal to the obstruction, you can hear a loud sound that is called as a whoosh type of sound. You can also measure ankle brachial pressure index, and depending on the ratio of that ankle brachial pressure index, you can get an idea what is the severity of obstruction. We know that 1.1 plus minus 0.2 is less than 0.9, less than 0.5, 0.3, and 0.1. Perfect, beta. So, this is how we can come to know that yes, this is a severity of obstruction. You've made your clinical judgment. You can confirm your clinical judgment by using a color Doppler. Angiography is not preferred because that is invasive. Once the diagnosis is made, you want to treat this patient. Patient is coming to you with ischemic symptoms. So what you want to hear is the patient's ischemic symptoms should disappear. And to make those ischemic symptoms disappear, what we want is we want to increase the distal blood supply. Okay? So to increase the distal blood supply, we first advise lifestyle modification by which the body can form the bypass channel on its own around the obstruction. It may take 6 months for these bypass channels or collaterals to develop. For that, we have to tell the patient, Bhaiya, stop that smoking, reduce weight, brisk walk 40 minutes morning, 40 minutes evening, dietary modification. If the patient follows your advice, the body will form the bypass channel on its own and the distal flow will increase and the patient's symptoms will decrease. But we know that many times patients cannot afford this expensive treatment, and then we have to think of doing something. We can give some medicines like vasodilators, cilostazol and oxypentyphylline, antiplatelets, which causes thinning of the blood, like aspirin if long term has to be given, and clopidogrel if for short term it has to be given. We can even do angioplasty, that is simple balloon angioplasty or a stent angioplasty, usually drug coated stent angioplasty, sirolimus coated. We can do surgeries like bypass surgery. In bypass surgery, we can make the graft. We can take this graft from the artery inside or from the vein inside. Generally, if we talk about coronary artery bypass grafting or heart bypass surgery, we are taking the internal mammary artery. Artery is stronger than vein, so artery will have long-term patency as compared to vein. These grafts which are taken from inside the body are called as autologous. Commonly the internal mammary artery, maybe the right or the left, maybe a great saphenous vein can be used, gastroepiploic artery can be used. If you don't want to use a graft from inside the patient, you can buy this graft from the chemist shop. At the chemist shop, there are synthetic grafts. They can be textile, non-textile. Textile means made of cloth, kapde ke graft. They can be woven or knitted. Woven are better than knitted grafts. They are Dacron grafts. And non-textile grafts, beta, they are PTFE, polytetrafluoroethylene. Most common cause of early graft failure is faulty technique by the surgeon. Most common cause of late graft failure is graft occlusion. Graft infection most often is by Staph aureus. If we have to choose, if there is a suprainguinal obstruction, for example, there is a aortoiliac obstruction, then in these cases, we prefer using a Dacron graft. If it is a iliofemoral obstruction, that is inguinal level obstruction, then we do angioplasty. If it is an infrainguinal obstruction like femoropopliteal obstruction, then we prefer using great saphenous vein. Most common peripheral bypass surgery done is a femoropopliteal bypass. Femoropopliteal bypass. There are certain situations like Burgess disease, wherein Burgess is actually a disease of small to medium-sized vessels. So in these cases, if there is a traffic jam, we encourage lifestyle modification, we can give medicines, but angioplasty at times is not possible, bypass surgery is not possible. Patient keeps on coming to you with pain in the foot at rest. Now, to relieve the pain in the foot, we can do a lumbar sympathectomy. In lumbar sympathectomy, beta, what we are doing actually is, we are making a incision in the lumbar region here. And then we are going into this lumbar sympathetic chain, which is lying next to the lumbar vertebra. So first, second, third, fourth lumbar sympathetic chain is removed. As soon as you remove this lumbar sympathetic chain, then what happens? The arterioles in the foot, they get dilated. If they get dilated here, they want more blood. So they steal the blood from the calf, and calf blood starts moving towards the foot. So if more blood comes in the foot, the rest pain will be relieved. But if by chance the patient had intermittent claudication, that is pain in the calf, and if you are doing lumbar sympathectomy, you are removing the calf blood, so calf pain will increase. That is why lumbar sympathectomy should not be done in intermittent claudication. If the patient has developed gangrene, then we have to do amputation. Right, Beta Ji? So I hope you know this concept, and now let's move further and see what all we are supposed to discuss here. Now, in this particular session, beta, first we will be talking about some important diseases, what we can come across, like Burgess disease and Raynaud's disease. Burgess disease is basically called as thromboangiitis obliterans. This is the disease which is seen only in smokers, or we can say only in those people who use tobacco, right? The textbooks, they write smokers, beta. But actually, it is related to tobacco. Why the textbook writes smokers? Because these textbooks are written by foreign authors. And suppose a UK author or a US author, he may not be aware that there is some other form of tobacco also which is commonly used in India, right? So even those people who eat this tobacco, they also can suffer from this Burgess disease. Usually, there is thrombosis, thrombophlebitis of small to medium-sized vessels. 95% patients are males, but as the incidence of smoking is increasing drastically in females, so even females are coming to us with this Burgess disease. Usually, the arteries, veins, nerves can be involved. Lymphatics are not involved in Burgess disease. Usually, the disease is seen in the lower limbs, but can also be seen in the upper limbs. Now, because if it is a disease of the small, medium-sized vessels, and suppose we are talking about the lower limb, then in the lower limb, it should be something related to the tibial vessels or maybe the dorsalis pedis vessel, right? The patient usually comes to us with rest pain. And we know that to relieve his rest pain, we have to increase the distal blood supply. And just now we talked about we have the option of lifestyle modification, medicines, and lumbar sympathectomy. Amputation has to be done in gangrene situations, right? So these are the treatment options in Burgess. Let's take a look what is written in our workbook. Just a moment. Right, beta. So Burgess disease, the other name of Burgess disease is thromboangiitis obliterans. Please be careful, beta. On 17th of December, the examiner may not write Burgess. He may simply write thromboangiitis obliterans, right? What happens here is there is thrombosis, thrombophlebitis, of small to medium sized vessels, small to medium sized vessels. It can be associated with Raynaud's syndrome. It can be associated with Raynaud's syndrome. Usually, if we take a look at the age group beta G, then it is seen in less than 45 years of age. Earlier, the books used to write less than 30 years of age. 95% are males, usually seen in the lower limbs, can involve the artery, vein, and the nerves, but it does not involve the lymphatics. It does not involve the lymphatics. Clinically, majority patients present with rest pain. We can take the help of Olin's criteria. Now, we just need to know the name of this criteria, though this has never been asked in the FMG exam. Olin's is something we commonly use in practice, wherein there are some certain things which we need to ensure. For example, the patient should be presenting with distal ischemic symptoms and signs. We should be able to diagnose these ischemic symptoms and signs. The patient should be a tobacco user. We should be able to exclude any other disease which is causing these ischemic symptoms. For example, diabetes, for example, any autoimmune disease. So we should be able to exclude all those diseases. And then we say that if there is no other disease, then it is a Burgess disease. In the treatment of Burgess beta, we can understand that mainstay here is lifestyle modification. And we actually tell the patient bluntly, beta, you can either have your cigarettes or your legs. But unfortunately, the patient chooses cigarettes. The actual practical situation, suppose there's a patient of this Burgess having rest pain. You have admitted this patient in the hospital because he's having severe pain. Now, beta, just try to imagine that if suppose, let me just try if I can do this here. Yeah, now this is what I wanted to do, beta. See, if suppose we say that this patient, suppose something like this. Now this patient, suppose if there is a traffic jam in this area, now this patient will feel better in lying down position or in a standing position. Right. So now I think I'll be able to explain this concept a little bit. Right. So now if suppose there is a traffic jam like this, there's a traffic jam like this. Now we know that the direction of flow in the arteries, the blood is flowing in this direction, right? So if the patient is standing or if the patient is sitting, then still there are chances that some amount of blood can go down. But if you ask the patient to lie down, then there is no gravitational pull also. So the chances of blood going down would be less. That means these arterial obstruction disease patient, very simple beta, if there's a traffic jam in the artery, then if the patient is sitting or standing, then because of the gravitational pull, there will be more chances of blood going down. But if this patient lies supine, or if suppose he tries to elevate the limb, for example, if I say this patient is trying to elevate the limb, now what will happen? We can understand what is happening here, right? So the flow towards the foot will decrease, right? So the patient will feel better if the patient is like this. So what actually we see in our clinical practice, beta, that when you go to this vascular surgery ward in the night, many times you find that you have asked these patients to stop smoking and all that stuff. But suppose 2 o'clock in the night, the patient cannot lie supine on the bed, because as soon as he is lying supine on the bed, the flow to the foot decreases and the pain increases. So he's either sitting on the bed and sleeping, or majority of the times you find that this gentleman is sitting somewhere in the corner of the ward and he's smoking that BD in the ward, right? This is the actual clinical situation. Just wanted to give you the concept, beta. Whenever we talk about arterial obstructions, obviously in a sitting or standing position, the flow towards the foot will be more. But as soon as the patient lies down or if he tries to elevate the limb, then the flow to the foot will decrease, right? So this is something which we as a doctor should understand conceptually. कि भैया आर्टरी में अगर ट्रैफिक जैम है, आई रिपीट दिस इन हिंदी बेटा, अगर आर्टरी में ट्रैफिक जैम होगा तो जब पेशेंट बैठा हुआ है या खड़ा हुआ है तब ग्रेविटेशनल पुल की वजह से ब्लड नीचे फिर भी आ सकता है, लेकिन जैसे ये पेशेंट लेटेगा या मान लीजिए अपने पैर को ऊपर उठाएगा तो ब्लड की सप्लाई फुट में और कम हो जाएगी, दर्द और बढ़ जाएगा। इसलिए ये जो पेशेंट्स होते हैं ये लेट नहीं पाते ठीक से, जब इनको सोना भी होता है तब भी ये बेड पे या तो बैठ के सो रहे होते हैं या कहीं दीवार के सहारे खड़े होकर सोने की कोशिश कर रहे होते हैं, राइट? सो I hope you have got this concept nicely, because in your exam the examiner may ask you कि भैया which patient will get relief in sitting position or standing position, which patient will worsen in supine position. Like if I say there is a traffic jam in the veins, okay, suppose let us just try to imagine veins here beta. Suppose I am using this blue color for the vein. Now if I say कि there is a traffic jam in the vein, if there is a traffic jam in the vein, then what is going to happen? The direction of flow in the vein is like this. Now if you ask this patient to stand, if you ask this patient to stand, what will happen? If you ask this patient to stand, then the venous drainage will be against gravity, so that will not be proper. The blood will be pooling in the lower part, right? But if you ask this patient to lie down, now as soon as you ask this patient to lie down, then yes, there is still a better chance of a venous blood to flow upwards. If you ask this patient to elevate the limb, if you ask this patient to elevate the limb, then yes, there are more chances that the blood will be flowing towards the heart, right? So if it is a venous obstruction, limb elevation helps. If it is an arterial obstruction, limb elevation worsens. Whatever we are talking in vein, the same story will be there in the lymphatics also. For example, if I say that this is the lymphatic channel, and there is a traffic jam in the lymphatic, suppose here. Now, the direction of flow of lymph normally is like this. But if there is a traffic jam here, and suppose you ask this patient to stand, now what is happening? Right? There's a traffic jam in the lymphatics here. So on standing, the flow of lymph towards the heart will decrease. So you ask this patient to lie down. And when this patient is lying down, now the chances of flow of lymph towards the heart will increase. If you ask this patient to raise the limb, put some pillow beneath the legs, then the chances of lymph flowing towards the heart will increase. That means we have understood this moral nicely, that arterial obstructions will worsen in supine or limb elevation things, but venous and lymphatic obstructions will be relieved on limb elevation, right? Okay, so this was the concept which I actually wanted to give you. समझ आया बेटा? I hope you are able to understand this. Fine. So here what we are trying to do in lifestyle modification, we are very, very blunt. Either cigarettes or legs, because it is the smoking, it is the tobacco which is creating all the problem. But this treatment we know is expensive, patients can't afford, so we can give some medical treatment. If that fails to relieve the rest pain, then we can do lumbar sympathectomy just to relieve the rest pain, right? Okay. चलिए जी, now let's take a look at another small pathology, but this is a hot pathology which has been asked 3 times in the last 5 exams. 3 बार सवाल आए हुए हैं. Raynaud's is basically a spasm of the arterioles. Okay, so what I'll do, first I'll explain this Raynaud's to you. Right, Raynaud's, this is commonly seen in young females. This is spasm of the arterioles, arteriole spasm, and especially on cold exposure. This can be primary Raynaud's or secondary Raynaud's. Primary when there is no other disease associated with it, and secondary when it is associated with some other disease, maybe systemic lupus erythematosus, maybe scleroderma, maybe rheumatoid arthritis, maybe thoracic outlet syndrome, cervical rib, and so on. So if there is no other disease, primary. If there is any other disease with Raynaud's, then it is a secondary Raynaud's. Okay. Now what actually happens, beta? Let us just try to understand a clinical situation. First I'll explain in Hindi, then I'll explain in English. Okay. एक छोटी सी चीज इमेजिन करते बेटा कि यंग फीमेल्स की हम बात करें तो मान लीजिए नई नई शादी हुई है, अभी अभी ससुराल में गई हैं. ससुराल में सासू माँ बरसों से इंतजार कर रही थी कि कब मेरी बहू आएगी और कब वो पूरे घर का कामकाज संभालेगी. तो नई नई बहू ससुराल में पहुंचती हैं, सासू माँ उनको धीरे धीरे सारे काम देना शुरू कर देती हैं. सारे घर के बर्तन उन्होंने करने हैं, सारे कपड़े उन्होंने धोने हैं. अब अगर मान लीजिए नई बहू रानी को Raynaud's है और जैसे ये कपड़े धो रही हैं या बर्तन कर रही हैं तो मान लीजिए ठंडा पानी दिया जा रहा है इनको साफ सफाई के लिए, तो जैसे ये ठंडे पानी में अपना हाथ डिप करती हैं वैसे ही यहाँ पे इनको कुछ कुछ होता है. यहाँ पे जो आर्टीरियोल्स हैं उनका स्पाज्म हो जाता है, सिकुड़ जाते हैं, और जैसे ही इसका स्पाज्म होगा तो वैसे ही ये एरिया एकदम पेल हो जाएगा, सफेद हो जाएगा. ब्लड के रुकने की वजह से धीरे धीरे ये नीला पड़ जाता है. और फिर जब बहू रानी अपने हाथ को गर्म करती हैं तो वापस से ये आर्टीरियल्स डायलेट हो जाते हैं और खून वापस से इन आर्टीरियल्स में आ जाता है, यानी कि ये एरिया लाल हो जाता है. दोबारा से देखिए बेटा, जैसे ही ठंडे पानी में हाथ दिया वैसे ही ये आर्टीरियल्स स्पाज्म में गए, ये वाइट हो गया, खून के रुकने की वजह से नीला पड़ गया, और जैसे फिर बहू रानी ने हाथ को ऐसे गर्म किया वैसे जो स्पाज्म हुआ था आर्टीरियल्स का वो खत्म हो गया और खून वापस से इस इलाके में आ गया और ये इलाका लाल हो गया. ये एक सीक्वेंस होता है कलर चेंजेस का Raynaud's में, वाइट, ब्लू, रेड, जिसको हम Raynaud's फिनोमिना बोलते हैं. अब ससुराल में बहू रानी जब भी कपड़े कर रही हैं, बर्तन धो रही हैं, तो उनको कुछ कुछ हो रहा है. शुरू में तो उन्हें लगता है शायद ऐसे ही कुछ है, लेकिन फिर धीरे धीरे वो अपनी सासू माँ को शिकायत करना शुरू कर देती हैं कि देखिए सासू माँ, मुझे नहीं पता कि यहाँ पे क्या है, लेकिन जैसे ही आप मुझसे बोलते हैं कि मुझे कपड़े धोने हैं या बर्तन धोने हैं तो मुझे कुछ कुछ होता है. तो सासू माँ को सब पता है. सासू माँ को लगता है कि ये नई बहू रानी है, ये मुझे सिखाने की कोशिश कर रही है कि कुछ कुछ होता है, ये कपड़े नहीं धोना चाहती, बर्तन नहीं करना चाहती, इसलिए नाटक कर रही है. तो सासू माँ जो है उसको इग्नोर करती जाती है. और एक दिन आता है जब बहू रानी परेशान हो जाती हैं, वो कहती हैं कैसी सासू माँ है, हमारे को कुछ कुछ होता है और इनको कुछ कुछ नहीं होता है. तो फिर बहू रानी जो है एक दिन हड़ताल पर चली जाती हैं. वो कहते हैं जी बहुत कर लिया मैंने काम, अब आज के बाद मैं काम नहीं करूं जब तक मेरी समस्या ठीक नहीं हो जाती. अब सासू माँ सोच में पड़ जाती हैं कि भैया अगर काम नहीं करेंगे तो फिर कल से क्या होगा. तो सासू माँ जो है बहू रानी को लेके आपके पास आती हैं अस्पताल में. समस्या सासू माँ को है कि कल से काम कौन करेगा. सासू माँ आपको बोलती हैं, डॉक्टर साहब ये मेरी बहू है, इसको बोलती हूँ कपड़े धो दे, बर्तन धो दे, बोलती है कुछ कुछ होता है, जरा देखिए क्या क्या होता है। आप बहुरानी को एग्जामिन करते हैं, जैसे बहुरानी का हाथ ठंडे पानी में डिप करते हैं तो वो आपको रेनॉल्ड्स फिनोमेना एकदम सफेद पड़ जाती है, नीला पड़ जाती है और फिर लाल हो जाती है। तो आपको लगता है भैया ये तो गड़बड़ बात है, इनको तो रेनॉल्ड्स है। अब इसके इलाज में हमें क्या करना है? हम चाहते हैं कि यहाँ पे जो ब्लड फ्लो है वो अच्छा हो, ठीक ठाक हो। इसके लिए हमारे पास जो ऑप्शंस हैं ब्लड फ्लो बढ़ाने के लिए, एक वो लाइफस्टाइल मॉडिफिकेशन है, एक मेडिकल ट्रीटमेंट था, एक एंजियोप्लास्टी, एक बाईपास सर्जरी, एक सिंपैथेक्टमी, एक एम्पुटेशन, ये ऑप्शंस थे। अब लाइफस्टाइल मॉडिफिकेशन में बहुरानी को बोल सकते हैं भैया ठंडे पानी में हाथ नहीं देना है, दवाइयों की कोशिश कर सकते हैं, कुछ कैल्शियम चैनल ब्लॉकर्स या नाइट्रेट्स दे सकते हैं जिससे आर्टीरियल्स खुले रहें। एंजियोप्लास्टी तो हम सोच भी नहीं सकते इन आर्टीरियल्स में, बेचारा फोगाटी कैथेटर कहां से जाएगा इधर। कोई बाईपास सर्जरी की भी हम नहीं सोच सकते इस इलाके में। सर्वाइकल सिंपैथेक्टमी का हम सोच सकते हैं। एम्पुटेशन, क्योंकि गैंग्रीन की कोई कहानी नहीं है तो एम्पुटेशन की भी कोई मतलब नहीं है। यानी कि अगर हम देखें तो हमारे पास लाइफस्टाइल मॉडिफिकेशन, दवाइयां और कभी कभी सर्वाइकल सिंपैथेक्टमी, यही ऑप्शंस हैं। इन तीनों ऑप्शन में सबसे अच्छा ऑप्शन है लाइफस्टाइल मॉडिफिकेशन। अब लाइफस्टाइल मॉडिफिकेशन में बहुरानी को ठंडे पानी में हाथ नहीं देना है, तो हम सासू माँ को समझाते हैं कि सासू माँ देखिए इनको तो रेनॉल्ड्स है, तो ये तो ठंडा पानी में हाथ नहीं दे पाएंगे, तो या तो आप कल से काम वापस शुरू कर दीजिए या बहुरानी को गर्म पानी दे दीजिए, बहुरानी को दस्ताने वगैरह पहना दीजिए जिससे इनको समस्या ना हो। तो इस तरह से हम रेनॉल्ड्स का ट्रीटमेंट कर सकते हैं। नाउ आई रिपीट दिस एंटायर स्टोरी इन इंग्लिश। आई एम जस्ट ट्राइंग टू गिव अ क्लिनिकल सिनेरियो कि हाउ दीज रेनॉल्ड्स पेशेंट कम टू अस इन प्रैक्टिस। जस्ट इमेजिन योरसेल्फ February 23. Raynaud's is something which is commonly seen in young females. As soon as the lady dips her hand in cold water, there is spasm of the arterioles. The arterioles here go into a state of spasm, because of which this becomes white. Due to stagnation of blood, it becomes blue, and then when the lady warms her hand, the arterioles dilate again and the blood starts flowing and this area becomes red. This is a characteristic sequence of color changes what we observe on cold exposure. First white, then blue, and then red. This is called as Raynaud's phenomena. Now, how these patients come to us generally? Let us just imagine a scenario. A young female who has just got married has gone to the in-laws' place. There the mother-in-law had been waiting for years together that when the daughter-in-law would come, she will be handing over all the household works to her. So gradually, the mother-in-law starts giving all the work to the new daughter-in-law. And the new daughter-in-law is supposed to wash all the utensils, all the clothes in the house. Now, when this new daughter-in-law is doing all this work, as soon as she is dipping her hand in cold water, there is something which is happening in the tip of the fingers because of spasm of arterioles. She notices that this area becomes white, then gradually it becomes blue, and then when she has to warm her hand, it becomes red. So she starts thinking that there is something which is happening inside. She tells the mother-in-law, "Hey, mother-in-law, look. As soon as I'm doing these washing the clothes or washing the utensils, there is something which is happening inside me." Mother-in-law knows all the tricks and trades of the daughter-in-law. So mother-in-law is not convinced. Mother-in-law just counsels the new daughter-in-law and she asks the daughter-in-law to continue doing the household works. Now the daughter-in-law is getting frustrated that what the hell is happening. Whenever I'm doing these household works, I'm having something. So this new daughter-in-law, one day she goes on a strike and she tells the mother-in-law that, "Look, mother-in-law, from tomorrow I'm not going to do any work." because I'm having this problem. Now the mother-in-law gets confused that if she is not doing, then who is going to do the work from tomorrow? So now the mother-in-law takes the daughter-in-law and brings to you in the hospital. February 23, you are in the OPD, white coat and the stethoscope. The mother-in-law, daughter-in-law walking into your OPD. And the mother-in-law is complaining, doctor, whenever I ask her to wash the clothes or wash the utensils, she's telling that she's having something inside. Please see what is that. You examine this new daughter-in-law. As soon as you see dipping the hand in the cold water, there is a characteristic white-blue red change. So you diagnose that, yes, this is the Raynaud's. And this is because of the spasm of the arterioles. We talked about that what are the different modalities in increasing the distal blood supply. Lifestyle modification, medicines, angioplasty, bypass surgery, sympathectomy. And if gangrene would have occurred, then amputation. So if we just try to look at all these modalities, lifestyle modification, yes, medicines, yes, angioplasty. Fogarty catheter is not going to go into these arterioles. Also, this is just happening on cold exposure, not a routine story. Bypass, no point in doing a bypass here. You cannot do a bypass in these arterioles. Sympathectomy, yes, we can do a cervical sympathectomy here. Amputation is not needed because there is no gangrene. So we take a look at what all treatment options we can offer in this patient. Lifestyle modification, medicines like calcium channel blockers and nitrates, and rarely cervical sympathectomy. Out of all this, the mainstay of treatment is lifestyle modification. And in lifestyle modification, we do not want cold exposure in this patient. So we can tell the mother-in-law, look, mother-in-law, she is having Raynaud's. So she will not be doing all this clothes and utensils. You will have to do all the household work from tomorrow. Or you give warm water for washing the clothes or washing the utensils. Ask this young lady to wear those gloves whenever she's working in water, because if by chance there is a cold exposure, she should not have this Raynaud's. So that is how we actually treat this Raynaud's. I hope simple concept, but since this has been asked thrice in the last 5 exams, so I thought that let us try to correlate this with the actual clinical situation, actual patients who are coming to us in the hospital. Right, beta. Raynaud's disease. This is a spasm of arterioles on cold exposure. Commonly seen in young females, upper limbs. Since this is a problem of the arterioles and not the arteries, so pulses are normal in Raynaud's. Primary and secondary. Primary when there is no other associated disease. And secondary associated with any other disease. This can be SLE, that is systemic, lupus erythematosus, rheumatoid arthritis, scleroderma, thoracic outlet syndrome, like cervical rib, thoracic outlet syndrome, like cervical rib. Now, you have to be careful on 17th of December, beta, how the MCQ can be framed here. They might give you a clinical story of Raynaud's. They might also give you an image of Raynaud's, which we are seeing just after this. And they may not give any other disease association, or they may not give any symptoms of any other disease. And they may ask you whether it's a primary or secondary. So if nothing else is given, then it's primary. But if they give any other symptoms associated with this Raynaud's presentation, like in SLE beta, we find a butterfly rash here. So on 17th of December, you can get two images in one question. There might be a butterfly type of rash here, and there might be an image of Raynaud's. And they may ask you whether it's primary or secondary. So that's a secondary. When you'll be reading about rheumatoid arthritis in orthopedics, you will know what is the presentation of rheumatoid arthritis. So if they're giving this type of presentation along with symptoms of Raynaud's, then it is a secondary Raynaud's. Thoracic outlet syndrome. Sometimes what happens, beta, if there is any extra mass or something sitting at the thoracic outlet here. Now in this mediastinum, right? If there is any mass lesion or something, or sometimes there is an extra rib, cervical rib, what we call that, right? So if there is an extra rib present here, now this can put pressure on the vessels inside. For example, if there is an extra rib in me here, now what will happen? Suppose I have got an extra cervical rib here, beta, right? Now, when you are examining me, you may be feeling the radial pulse normally. But if you ask me to turn my head to this side, now if I turn my head to this side, if there is an extra cervical rib, this will put pressure on the subclavian artery. And if the subclavian artery is pressed, then supply to my radial artery will decrease and the radial pulse may disappear. You ask me to turn the head like this, now there is no pressure, radial pulse will reappear. This is what we call as Edson's test, and this can tell us whether there is any thoracic outlet syndrome or not. I repeat this test, beta. Edson's test is what we call it. We'll write this also. Basically, if there is an extra rib present here. Now, when you're examining this patient in a normal position, you may feel the peripheral pulses to be normal. But if you ask the person to turn the head on the side, affected side, then this cervical rib will be pressing on the subclavian artery, so the distal supply will go off and the radial pulse will disappear. Now you ask the person to turn the head in front. Now there is no pressure on the subclavian artery, blood flow starts in the radial artery and the radial pulse reappears. This is Edson's test, how we can test for a cervical rib. So beta, this type of clinical situation might be given to you, and then Raynaud's symptoms might be given to you, or maybe image of Raynaud's might be given to you. So all this will come under secondary Raynaud's, right? Fine. You can just make a note here, beta, that Edson's test. Edson's test is for cervical rib. In Raynaud's disease, we see a characteristic sequence of color changes. Like here what you're seeing, beta, just look at it, that as soon as you have asked this patient to dip her hand in cold water, so what has happened? There is spasm of the arterioles. So all this area has become white. Now because of stagnation of blood here, this area becomes blue. This becomes blue. Now you ask this lady to warm her hands. As soon as she warms her hand, the blood flow starts coming back. So this area will become red. This characteristic sequence of color changes: white, blue, and then red. This is what we call as Raynaud's phenomena, right? So Raynaud's phenomena is a characteristic sequence of color changes. The sequence of color changes: white, then blue, and then red. In the treatment for this Raynaud's bitter, the mainstay of treatment is lifestyle modification, where we tell the patient to avoid any cold exposure, wear warm clothing or gloves, we can advise medical treatment. In medical treatment, we can advise the patient some calcium channel blockers and nitrates. And this was the question on 4th of June 2022. They asked which of the following is used in the treatment of Raynaud's, and the options were calcium channel blockers, alpha blockers, beta blockers, and something else, aspirin. So the answer was calcium channel blockers. Rarely we can opt for a cervical sympathectomy. Now here also, beta, you know the role of sympathectomy. Whenever we are chopping the sympathetic tone, for the foot we were doing lumbar sympathectomy, for the hand we are doing cervical sympathectomy. So if you're chopping the cervical sympathetic chain here, the arterioles in the pulse spaces of the fingers will dilate and they will drag more blood, right? But generally, these cervical sympathectomies are not needed. The problem is not that severe that you open the neck of the patient and do this sympathectomy, right? Okay. So this was a story related to some Burgess and Raynaud's disease. Now, let us talk something about a sudden arterial obstruction. Sudden arterial obstruction we can understand better as this is something which is happening suddenly, acute onset, right? Now, in this sudden story, we are talking about the arterial obstructions, bit arterial obstruction, right? Suppose this is the aorta, and suppose this is the common iliac. This may be the external internal iliac, external iliac. This is the femoral, and suppose this is the popliteal artery, and then it would be further dividing into anterior posterior tibial, and the anterior tibial would be going down as the dorsalis pedis, right? Now, sometimes what can happen, beta, if we focus that God has given us this heart here, suppose this is the story here. We know God has given us the valves. There are heart valves, and there is a pathology called as subacute bacterial endocarditis. In that, what happens, Peter? There are some vegetations which are sitting over the heart valves. Now, let us just imagine a situation where the heart suddenly fibrillates. Heart suddenly fibrillates. Now, if the heart suddenly fibrillates, what will happen? These vegetations, what you are seeing inside, these vegetations which are sitting over the heart valves, these vegetations will be lifted off from the heart, and these vegetations may come into the circulation. Now, when these vegetations are traveling in the circulation, there is a possibility that these vegetations can go at any place in the body. Suppose we are imagining that this is going into the common iliac, into the external iliac, into the femoral, into the popliteal, and suppose it causes a complete traffic jam in the popliteal artery. Now, if there is a sudden complete traffic jam in the popliteal artery, we can understand that now there is nobody who is supplying blood to the distal part. No blood supply to the distal part. And this is a sudden arterial embolism. That means the body does not have any time to form the bypass channels or collaterals here. This part is not receiving any blood supply. The patient will present with severe pain. This part will become pale. This part will develop paresthesias, paralysis type of features. No pulses will be palpable in this area, pulseless. And this part will become cold, poikilothermia. So in sudden arterial obstructions, they are acute obstructions, acute limb ischemias. The patient does not have any time to form the collaterals. And in these cases, since there is no blood supply to the distal part, the patient presents with various P's: pain, pallor, pulseless, paresthesia, paralysis, and poikilothermia. Now, this is a dire emergency situation for us, beta. If you don't act immediately, then no blood supply to the distal part, this part will become gangrenous. And if this becomes gangrenous, beta, the treatment for gangrene is, yes, what is the treatment for gangrene, beta? Amputation, right? So there is a risk that patient might lose his limb. And you are the doctor. You are the boss. You are the second god. So your aim in these situations is, you don't want gangrene in this patient. As soon as this patient comes to you and you examine this patient quickly, that, oh my God, there are no distal pulses. Earlier, the patient was absolutely fine. Maybe 1 hour back, the patient was absolutely fine. But suddenly the patient has developed something like this. Now, immediately what we have to give, the first medicine what we give here is heparin. Heparin, low molecular weight heparin. Heparin is not going to break this thrombus. Heparin is not a thrombolytic, but heparin will not allow further platelets or something to aggregate on this. That means heparin will prevent enlargement of the thrombus. Heparin will prevent migration of the thrombus, right? So this thrombus will stay here. Now what we want is, we want to remove this thrombus. If we have to remove this thrombus, beta, what we can do, suppose this, what we talked about, this is the femoral artery here. And this, what we are seeing is the popliteal artery, right? And here we are talking about that there is a thrombus which has caused a traffic jam type of situation, right? Now we want to lyse this thrombus. We want that this thrombus should be broken. If you are able to break this thrombus, beta, if you are able to dissolve this thrombus, then immediately the distal supply will start and this everything will become normal. In order to lyse this thrombus, in order to dissolve this thrombus, beta, we can take the help of thrombolytic agents like tissue plasminogen activator, streptokinase, urokinase medicines. We can even deliver these medicines directly into the thrombus. How you can deliver, beta? You can just make a small opening. Suppose you make a small opening in the femoral artery. And then through this femoral artery, beta, you can pass a catheter. You can pass a catheter into the femoral artery. The same Fogarty catheter, beta. Now the Fogarty catheter is going here. You keep the tip of the Fogarty catheter into the embolus, right? And now through this, you deliver those medicines, streptokinase and urokinase. So these medicines will come here and they will dissolve the thrombus. And if the thrombus is dissolved, beta, the traffic jam is cleared, distal supply is restored, the patient's limb is saved, and salute to you. sometimes beta, this thrombolysis may not help. In those cases, we can try attempting embolectomy or thrombectomy. Embolectomy or thrombectomy. That is, we want to remove this thrombus. How we can do that, beta? Again, we can make a small opening here in the femoral artery, and through this, we can try passing the Fogarty catheter. Now, suppose you are passing the Fogarty catheter from here. Try to negotiate this Fogarty catheter through the side of the embolus. Take this Fogarty through the side of the embolus. See, I'm just trying to take this Fogarty through the side of the embolus. If I'm able to do that, then we know there is a balloon in the Fogarty catheter. We can inflate this balloon. And when we inflate this balloon, now you bring this Fogarty catheter back. With the inflated balloon, what will happen? This embolus will also be coming up like this. As soon as you see the embolus reaching in this area, you can just pick up the embolus from here. And this is what we call as embolectomy or thrombectomy. So that is how beta we can remove this embolus, clear the traffic jam, and restore the distal blood supply. Right? So this is what we do in sudden arterial obstructions. Now let's see what all is written here, beta. Sudden arterial obstruction is basically acute limb ischemia. This is actually acute limb ischemia. This is sudden occlusion of a vessel by a substance which is foreign to the bloodstream. Most common source of origin of this arterial embolism. Dhyan rakhna beta, please be careful. This is arterial embolism, not venous embolism. Venous thrombus more commonly seen in the calf veins, soleal veins. But arterial emboli most commonly originate from the heart. Okay, I repeat this beta. Arterial emboli most common originate from the heart. Venous thrombus most commonly seen in the calf vein. This is acute limb ischemia beta. That venous thrombus story is a deep vein thrombosis. Do not mix the two stories. One is in the artery, another is in the vein. Chali beta, most common source, it is the mural thrombi from the heart. Mural thrombi from the heart. It is a sudden story which is taking place within minutes. Does the body have time to form any collaterals, beta? No. This has been asked in the recent exams. All of the following are true about acute limb ischemia except, and one of the option was collateral formation is seen. There are no collaterals which can develop an acute limb ischemia. This is a vascular emergency. We know that collaterals takes months to develop. The patient presents to us with various P's. Pain which is severe and out of proportion to the clinical signs. Pallor, pulseless, paresthesia, paralysis, and poikilothermia. Poikilothermia means cold. Thermia, temperature. Poikilo, cold. ठंडा पड़ जाता है. अगर खून की सप्लाई बंद हो गई कहीं पे तो वो इलाका ठंडा पड़ जाएगा. Right. In the treatment beta, this is an emergency situation. The first medicine what we give is a low molecular weight heparin. We know this is not going to dissolve the thrombus, but yes, it will prevent enlargement of the thrombus, extension of thrombus, and migration of thrombus. It prevents extension of thrombus. Then we use thrombolytic agents. The standard thrombolytic agent is tissue plasminogen activator, like we can use streptokinase and urokinase. Streptokinase and urokinase. If this does not help, then we can do thrombectomy or embolectomy. Thrombectomy or embolectomy. So that is how sudden arterial obstructions have to be dealt with. Another pathology here, AV fistula. Now fistula beta, yesterday we were talking about what are the fistula. दो लोगों के बीच में जब कोई abnormal रिश्ता होता है उसको अपन fistula बोलते हैं, abnormal relationship between two people. Now AV, artery vein, arteriovenous fistula. तो ये क्या हुआ बेटा, arteriovenous fistula. Now suppose this what you are seeing is the artery, and suppose this is the vein. Normally we know that the direction of blood flow in the artery, suppose it is moving in this direction, then in the vein this will be moving in this direction. This is something what we see normally. Both are separate, no issues. But sometimes if suppose there is a penetrating trauma, किसी ने चाकू मारा है, or if somebody hits a knife, what can happen? Because of injury, inflammation, healing, many times during healing, abnormal connection can develop between artery and vein. Suppose I say that here, this is the abnormal connection which has developed. This is the fistula. Now, if there is an abnormal relationship between artery and vein beta, we all can understand which is having more pressure, artery or vein. Artery. Artery में ज़्यादा pressure है ना बेटा. So what will happen here? The blood will start flowing from the artery into the fistula. Blood will be going here also. Blood will be coming here also. So suddenly you see more blood has started coming into the vein. Now if I say there is a AV fistula in my arm here, suddenly more blood from the artery is going into my vein. And we know that vein wall is weak. Vein की दीवार कमजोर होती है ना बेटा. So whenever more amount of blood is coming in the vein gets abnormally dilated and tortuous, which we call as varicose. So in AV fistulas, we find this abnormal dilatation and tortuosity of the veins. Right? They become somewhat like this. Also beta, as more blood has started coming into the vein, so what will happen? There will be more venous return, more blood going towards the heart quickly. If more blood has started coming into the heart quickly, then the heart will have to increase the cardiac output. So in AV fistulas beta, we can find these engorged dilated veins, raised venous return, increased cardiac output. These are the presentations of the things what we see in AV fistulas. A very simple sign what you can elicit here is, if suppose there is a AV fistula in my elbow, suppose here, right? Now what is happening here? Suppose here is the artery and here is the vein. Blood from the artery is going towards my vein. If I apply pressure over the artery proximal to the fistula, इसका मतलब अगर मान लो मैं यहाँ पे आर्टरी पे कोई प्रेशर लगा दूं, आर्टरी को दबा दूं, if I just press this artery, what will happen? If I put pressure over the artery beta, the blood supply to the fistula will decrease, blood supply to the fistula will decrease, venous return will decrease, cardiac output will decrease. Just by putting pressure over the artery proximal to the fistula reverses the changes of AV fistula. This is called as Branham sign or Nicoledoni sign. क्या बोलते बेटा इसको? Branham sign or Nicoledoni sign. Okay, I repeat this once again beta. In AV fistulas, arterial blood going into the vein getting abnormally dilated and tortuous, increased venous return, increased cardiac output. If we apply pressure over the artery proximal to the fistula, the blood flow in the fistula will decrease, venous return will decrease, cardiac output will decrease. Pressure over the artery proximal to the fistula reverses the changes of AV fistula. This is called as Branham's or Nicolet-Doni's sign. In the treatment of AV fistula, beta, as we talked yesterday, fistula anywhere in the body, we don't want these abnormal relationships. So here, earlier, we used to destroy this relationship by putting sutures at 4 places. One suture here, another suture here, one suture here, another suture here. And that was called as quadruple ligation. But nowadays, beta, we have got that MCQ catheter which we are continuously using in vascular surgery now. So what we can do, that Fogarty catheter, right? We know there is a balloon in the Fogarty catheter. We can put some embolus in the Fogarty catheter. We can put an embolus in the Fogarty catheter, like here. We can just put some embolus, some substance, and we can take this Fogarty catheter with the embolus and try to put the embolus in the fistula. For example, you can make an opening in the artery here. You can pass the Fogarty catheter like this, take the Fogarty catheter into the fistula, and then just put the embolus into the fistula. So if you put the embolus in the fistula, beta, you know that you have stopped the connection of the artery with the vein. This putting an embolus in the artery is called as angioembolization or therapeutic embolization. Nowadays, beta, this angioembolization, therapeutic embolization is something which is used very frequently. Not for these AV fistulas because they are not that common, but bleeding from various areas in the bodies is quite common. Sometimes patient presents with upper GI bleed, sometimes presents with a lower GI bleed, sometimes respiratory tract bleed, sometimes genitourinary tract bleed. Just imagine, beta, that if there is any pipeline inside the body which is having blood, and if that starts leaking, suppose I say there is a vessel of the upper GI tract, right? And suppose there is bleeding taking place, the blood is coming out here. That means there is a leak in this area. Normally the story should have been like this, but now what has happened? The story has become somewhat like this. So what we can do, beta, we can take the help of same Fogarty catheter, take the Fogarty catheter with a embolus. Herein, the embolus what we can use is something which is in the shape of a coil, something which is in the shape of a coil. And there are hooks by which this embolus can be attached to the vessel wall, right? So now, beta, can you see, can you appreciate that you are able to stop the bleed? This is called as angioembolization or therapeutic embolization. And this is something which we are using very commonly, right? Now let's see what all is written here. Most common cause for arteriovenous fistula, it is penetrating trauma. We also make these AV fistulas, that is iatrogenic for dialysis purpose. AV fistulas can be associated with various infections, bacterial, viral or parasitic. In this AV fistula, we find abnormal dilatation and engorgement of the vein, where the risk of bleeding would be high. Chances of ulcers over the skin would be high, because if there is more amount of blood coming into a superficial vein, then this pooling of blood in the vein will keep on putting pressure on the overlying skin, and continuous pressure on the skin, a day can come when the skin ulcerates. In AV fistulas, there would be increased venous return, there would be increased cardiac output. Pressure over the artery proximal to fistula reverses the changes of AV fistula. This is called as Brenham sign or Nicoledoni sign. Brenham sign or Nicoledoni sign. This has been asked in our MCQs in the last 5 exams. Brenham sign is seen in. Answer is AV fistula. The treatment for these AV fistulas is angioembolization. Angioembolization, which is also called as therapeutic embolization. Therapeutic embolization. Earlier, we were doing surgery where we were doing a quadruple ligation of the fistula. We were ligating the fistula at 4 places, beta. 2 near the artery, 2 near the vein. This was called as quadruple ligation, but now this has become obsolete and we are preferring this angioembolization. We can just make a note that this angioembolization, you can just make a note, angioembolization is commonly used now to control upper GI, lower GI, upper GI, lower GI, respiratory tract, genitourinary tract bleeds. Genitourinary tract bleeds. Angioembolization is commonly used now to control upper GI, lower GI, respiratory tract, genitourinary tract bleeds, and most common substance used as embolus is a coil. Most common substance used as embolus is a coil. This bit of what we have put here, this is a coil. This structure, what you're seeing now, beta, this is just as a coil. Other substances which can be used as embolus include human dura mater. We can use human dura mater as an embolus, blood clot, ethyl alcohol sponge. These are the substances which can be used as embolus, right? Just a brief overview about angioembolization, because this is something what we are doing very commonly nowadays. And beta, when we'll be reading about hematemesis in adult surgical problems, a patient coming to us with hematemesis is vomiting of blood. So if there is any upper GI bleed, we can do that angioembolization. The last topic in arteries is aneurysm. Aneurysm, beta, is simply an abnormal dilatation of the vessel. What you are seeing here, beta, this is an abnormal dilatation of the artery, right? Why this abnormal dilatation occurs? जैसे जैसे उम्र बढ़ती है, इमारतें कमजोर होने लगती हैं. As we are growing older and older, the tissues in our body are becoming weaker and weaker. And just imagine 70-year-old, 80-year-old gentleman or a lady whose artery wall has become weak, if suppose the pressure in the artery is more, then there might be a situation when this high pressure in the artery may force the weak wall of the artery to protrude outside, and that can lead to abnormal enlargement of the artery. That is what is a aneurysm. Now here in beta, just to repeat or just to pictorially explain this concept, suppose this is the artery. Now what is happening beta? If the wall of the artery is becoming weak, suppose I say that this area of the artery is becoming weak, and suppose the pressure inside the artery is more, then whatever blood is flowing inside, that blood is going to put pressure on this wall, and this wall can abnormally enlarge. And now what will happen? The enlargement will be something like this. This abnormal dilatation of the artery, what we are seeing, this is the aneurysm. Now, if blood is continuously allowed to flow into this aneurysm, we know this aneurysm may keep on increasing, and a day might come when this aneurysm can rupture. And if this artery aneurysm ruptures, we can imagine that huge amount of blood loss will occur and patient will lose the life. So that is the importance why we need to know about these aneurysms. We can classify these aneurysms into true and false. If we look at the different layers of the artery beta, we know that if suppose this is the artery, then the artery would be having the innermost layer, that is the intima. Then there will be the muscle layer, that is the adventitia. That is the media. And then the outermost layer would be there, which will be the adventitia. So these are the three layers. The greenish one is the intima, the brownish one is the media, and the pinky one is the adventitia. If there are all three layers present in this aneurysm, for example, the intima is somewhat like this, and there is an intima like this, then media is also present here, so there is a media present here. And if adventitia is also present in this aneurysm, then such aneurysms are called as true aneurysms. But sometimes what happens beta, if there is more pressure in the artery here, then the muscle layer which is present here, there is a possibility, this was the muscle layer suppose, because of high pressure, the muscle layer will stretch, and because of the stretching of the muscle layer, there is a possibility that only intima starts protruding out. Now, for example, if only intima is protruding outside, muscle layer is here like this, adventitia is here like this, there is no muscle layer or adventitia here. This is called as a false aneurysm. This was a true aneurysm where all layers of the artery were present. This is a false or pseudo aneurysm where not all the layers are present. Usually the intima is present. That's it. These false aneurysms are more commonly seen in the femoral artery, especially those arteries beta where we keep on doing arterial punctures. अगर हम बॉडी में किसी आर्टरी में बार बार पंचर करते रहेंगे तो उस आर्टरी की दीवार कमजोर हो जाएगी ना. The wall of the artery will become weak, so the chances of aneurysm in that area will increase. Now herein, if the patient develops aneurysm, and suppose we talk about a abdominal aortic aneurysm, then Usually these patients remain asymptomatic, no problems. They come to the hospital with some or the other abdominal problem. We do the ultrasound and we come to know, oh my God, this gentleman is having abdominal aortic aneurysm. Now, in this asymptomatic patient, if the size of the abdominal aortic aneurysm is less than 5.5 centimeter, we closely follow up these patients with serial ultrasounds. Because the risk of rupture in an abdominal aortic aneurysm less than 5.5 centimeter is less. So we just keep on following whether the aneurysm is increasing or not. If by chance the patient is asymptomatic, but the size of the aneurysm, abdominal aortic aneurysm, is more than 5.5 centimeter, that means that the risk of rupture is high and we cannot take any chances. We have to do the treatment for these asymptomatic aneurysms also. Generally, the dictum is, beta, as a doctor, we never treat papers, we treat patients. You will come across so many situations, maybe in your family, relatives, friends, that you might be getting some reports on WhatsApp that this is the report of the relative, please advise the treatment. And they will not mention what is the problem to the patient. So we don't treat the reports. We treat the patients. We treat the patient problems, right? But here we know that even if the patient is not having any problem, but the size of the aortic aneurysm is more than 5.5 centimeter, the risk of rupture is high, so we should do the treatment now, right? Sometimes the patient can present with symptoms, maybe mild abdominal discomfort is there. So if the patient is having any discomfort, sometimes because of this aneurysm, there are pulsations which the patient can feel. Generally धक धक यहाँ पे होती है, लेकिन abdominal aortic aneurysm में पेट में धक धक होने लगती है. Generally we know it is the heart which is beating, but in aneurysm sometimes the patient may feel that beating artery, the expansile pulsations. So patient might be symptomatic. If the patient is symptomatic, then yes, whatever is the size, we need to do the treatment for these aneurysms. And my dear lovely friends, you would be surprised to know the treatment of these aneurysms is very simple. What you can do is, with the help of same Fogarty catheter, what we can do is, we can just put a stent into these aneurysms. For example, suppose this was the aneurysm. Why we want to treat? Because we don't want this aneurysm to rupture. So you can take the help of Fogarty catheter, and with the help of Fogarty catheter, you can take a stent and you can just put a stent here like this. Right? Now what is happening, beta? The blood is flowing in this direction, suppose. The blood is flowing through the stent now. Will the blood be going into the aneurysm? No. Will there be risk of rupture? No. Right? So just put a stent into this aneurysm and that is all what we are supposed to do. This is called as endovascular aortic aneurysm repair. क्या बोलते बेटा इसको? What do we call this? Endovascular aortic aneurysm repair, or EVAR. Now let's see what all is written in this aneurysm. Aneurysm is simply abnormal dilatation of an artery, commonly seen in elderly people. जैसे जैसे उम्र बढ़ती है, इमारतें कमजोर होती हैं. As we are growing older, the tissues, the walls at every place in the body is becoming weaker and weaker. They can be classified as true or false. True, where all the layers are present in aneurysm. False, not all layers are present in the aneurysm. Peripheral aneurysms, they are more commonly seen in the popliteal artery. Peripheral aneurysms, more common in the popliteal artery. but pseudoaneurysm or false aneurysm is more common in the femoral artery, because femoral artery is what we are commonly using for taking arterial samples, right? Usually, these aneurysms patient are asymptomatic, no symptoms to the patient. S oblique T beta, this is sometimes the patient may experience expansile pulsation or abdominal discomfort. No active treatment is required if the patient is asymptomatic and an aortic aneurysm is less than 5.5 centimeter. Best investigation or investigation of choice is a CT scan. If the patient is symptomatic or there is more than 5.5 centimeter abdominal aortic aneurysm, then the risk of rupture is high, and then we have to do some treatment, and the treatment what we are doing is a EVAR. This is endovascular aortic aneurysm repair. Endovascular aortic aneurysm repair. Right, beta. So this is all about the arterial disorder story. In arterial disorder, we talked about gradual arterial obstruction like atherosclerosis. There we also discussed Burgess disease and Raynaud's disease. Then we talked about sudden arterial obstruction. Then we talked about arteriovenous fistula. And finally, we talked about aneurysms, right? Here, what we'll do, beta, we'll take a break here, 20 minutes break, and then we'll be back with the venous disorders.
तो सर त्रिवेंद्रम में
Right, my dear friends. So let's take a look at the venous disorders now. And in this, basically, let us just try to understand that what is the story of these veins, right? So, if we take a look at the basic venous anatomy, how these veins are actually located. Suppose, like here, this area what we are seeing, beta, this area what we are seeing, this is the foot area, right? Now, in this foot, there is a dorsal venous arch here. The medial aspect of this arch, beta, the medial side of this arch, this becomes the great saphenous vein. And this great saphenous vein ascends near the medial malleolus. It is going like this into the leg. Then it goes to the posterior side of the leg. And then it comes up like this. And here it opens into the femoral vein. So this is the great saphenous vein. While on the lateral aspect, if we take a look here at the lateral malleolus, then here there would be a short saphenous vein, and this short saphenous vein will be opening into the popliteal vein in the popliteal fossa. So basically, beta, if we take a look at the venous anatomy of our lower limbs, there are superficial veins, there are deep veins. Superficial veins, beta, will be superficial, which will be located just beneath the skin. The deep veins will be located deep within the muscles. And then, apart from this, there would be some connecting veins which we call as perforators, right? I repeat this, beta. There will be superficial veins, the great saphenous vein and the short saphenous vein. These are the superficial veins. There would be the deep veins. The deep veins will be located deep within the muscles. And there would be connecting veins which will be connecting the superficial and the deep veins. They are the perforators, right? If we talk about the superficial veins, then suppose this here in the foot is the dorsal venous arch. The medial side becomes the great saphenous vein, and this great saphenous vein around the medial malleolus, it ascends into the leg somewhat like this. It keeps on going, and here it opens into the femoral vein at the saphenofemoral junction. On the lateral side, there would be a short saphenous vein, and this would be opening into the popliteal vein at the saphenopopliteal junction. If we just try to understand, like suppose I say that this is the superficial vein and this suppose is the deep vein. Now deep veins would be something like maybe the tibial veins, popliteal veins and the femoral veins. Okay, this great saphenous vein is opening into the femoral vein here, and the short saphenous vein would be opening into the popliteal vein here. So this will be called as the saphenofemoral junction. This will be called as the saphenopopliteal junction. And my dear friends, there are valves in the veins which we all know about. The direction of valves in these veins is such that they can allow the blood to move from superficial into deep, but these valves will not allow the blood to move from deep to superficial. So this is not possible. This is not possible. This is not possible, right? Because there are valves present here. So this deep venous blood will not be able to go into the superficial vein, right? Okay, fine. Also, we know that because of these valves, what happens as the blood is moving in this direction. So whatever blood has moved in this direction, that blood cannot fall back because of the valves, right? If we have got this little concept about the veins in the lower laminar leg, then our life really becomes very simple and very easy. Now we'll just try to understand the story of varicose veins, right? In a normal individual, beta, what happens? When a normal person is walking, what happens? The muscles of the leg are contracting, and because of the contraction of the muscles, especially of the calf, this muscle is putting pressure on the deep veins. Deep veins are located deep within the muscles. That means when the calf muscle is contracting, it is putting pressure on the deep vein. So blood in the deep vein is moving upwards as there is more pressure in the deep vein. As the blood is moving upwards in the deep vein is becoming empty. So the superficial vein will put their blood into the deep vein, right? That means in a normal person, in you, beta, what is happening? When you are walking, muscles are contracting, and because of the contraction of these calf muscles, there is pressure generated in the deep vein. The deep vein blood is moving upwards. The superficial vein is also pouring their blood into the deep vein. That means superficial veins are also getting empty, and that is how the venous return towards the heart is taking place. That means in a normal person, on walking, pressure in the superficial vein is falling because blood from the superficial vein is moving towards the deep veins. Now, what can happen sometimes? If suppose somebody is standing for long periods, now what can happen, beta? Suppose we talk about the traffic policemen. So you know, beta, traffic policemen, they keep on standing right from morning till late in the evening. That means because of standing, there is more pooling of blood in the veins lower down. The blood is not easily able to move up. So there is high pressure in the deep venous system. Now, this high pressure in the deep venous system can put pressure on the valves. If there is more pressure in the deep vein, beta, this will exert pressure on the valves in the superficial vein, right? So there is a possibility that these valves become incompetent. क्या हो जाएगा बेटा इन valves को? What will happen to these valves? They can become incompetent. खराब हो सकते हैं ये valve, right? Or if we imagine a situation that if suppose somebody is putting pressure on the inferior vena cava. Now, inferior vena cava, beta, inferior vena cava is something which is located in the abdomen, right? Inferior vena cava is receiving the common iliac veins. Common iliac veins formed by the internal iliac vein and the external iliac vein. External iliac vein is actually a continuation from the femoral vein, and femoral vein is a continuation from the popliteal vein. This what we are seeing in this diagram here, suppose this is the femoral vein, right? Now, if suppose there is somebody who is putting pressure on the inferior vena cava, that means the blood from this femoral vein will not be able to go easily into the inferior vena cava if inferior vena cava is compressed. That means there will be more pooling of blood in these veins, more pressure in these veins, more pressure on the valves, and these valves can become incompetent. Just imagine a scenario beta. During pregnancy में माँ 9 महीने तक बच्चे को अपने पेट में रखती है। 9 महीने तक ये बच्चा माँ के पेट में माँ की इंफीरियर वीना केवा के ऊपर बैठा रहता है। During pregnancy, for 9 months, the mother is carrying the baby inside the abdomen. And for 9 months, this baby is actually putting pressure on the inferior vena cava of the mother. So you can imagine, the blood flow from the deep vein is not proper because the IVC is getting compressed. So there will be more pressure in the deep venous system, more pressure on the valves, and the valves will become incompetent. If this valve become incompetent beta, since deep vein has got more pressure, the blood will start moving from deep to the superficial vein. Just imagine, if this valve becomes incompetent, if this valve is damaged, now when the person is walking, muscles are contracting, and when these muscles are contracting, they are putting pressure on the deep veins. So blood from the deep vein is moving upwards. Blood from the deep vein is moving upwards. Till the time this valve is normal, whatever blood is moving upwards, that blood cannot go into the superficial vein. But if this valve has been damaged, this blood will start moving into the superficial vein. More amount of blood will come into the superficial vein. The vein is weak, and this vein will not be able to tolerate such huge amount of blood, and then this superficial vein will become abnormally dilated and tortuous. This abnormally dilated and tortuous superficial vein is what we call as the varicose vein. So more blood has started coming into the superficial vein, and this is becoming abnormally dilated and tortuous. Any abnormal dilated tortuous vein is called as varicose. This is the reason why beta, that after pregnancy, the chances of varicose veins are high. I repeat this concept once again. During pregnancy, when the baby is sitting on the inferior vena cava of the mother, the inferior vena cava is getting compressed. So blood which is flowing from the femoral vein into the external iliac, into the common iliac, into the inferior vena cava, the flow of blood will not be proper. There will be pooling of blood in the femoral vein, more pressure in the femoral vein, and this more pressure will make the saphenofemoral valve incompetent. And then blood from this femoral vein will start moving into the superficial vein, and this will cause dilated, tortuous, great saphenous vein, that is the varicose vein. Right? So I hope you have understood this concept nicely, beta. Now what is happening in this particular patient? When this person is walking, muscles in the calf are contracting, so pressure in the deep vein is increasing. Now because of high pressure in the deep vein, more blood is coming into the superficial vein on walking. So now more blood coming in the superficial vein on walking will increase the pressure in the superficial vein, and this is what we call as ambulatory venous hypertension. Ambulatory, चलते समय जब ज़्यादा blood superficial vein में आ रहा है, while walking, when more blood is coming into the superficial vein, pressure in the superficial vein is increasing, and that is called as ambulatory venous hypertension. Ambulatory venous hypertension. Right? So I hope we have got this concept nicely. Any traffic jam situation in the deep veins beta, this will not allow the blood to move from deep veins upwards. So there will be pooling of blood in the deep veins. There will be more pressure in the deep vein, and if the valves are incompetent, then blood from the deep vein will be going into the superficial vein, and the superficial vein will be getting abnormally dilated and tortuous varicose vein. Whether it is pregnancy story or if there is a pelvic tumor, like in obs and gynae we read about a tubo-ovarian mass, that tubo-ovarian mass may also be putting pressure on the inferior vena cava. Deep vein thrombosis, Sometimes what happens, beta, if there is a thrombus which is developed in the deep vein. Now, because of this thrombus, there is a traffic jam in the deep vein. The blood cannot move up nicely. So the blood will be getting diverted into the superficial vein through the saphenopopliteal, or maybe through the perforators, which are the connections between superficial and deep vein. So even in case of deep vein thrombosis, there is a risk of varicose veins. Usually, females are more commonly affected with these varicose veins. What is going to happen in these patients? Most commonly what we see, it is a saphenofemoral valve. Saphenofemoral valve which becomes incompetent, more amount of blood coming into this. So the patient, because of pooling of blood, may experience some aching discomfort. मीठा मीठा दर्द हो सकता है in the calf region and in the heel area. Because these are abnormally dilated tortuous veins, even a small amount of trauma can cause injury in these veins and they may start bleeding. Apart from this, beta, you can very well make out that if this is the great saphenous vein and if saphenofemoral valve is the most common valve which becomes incompetent, then it is a great saphenous vein which will bear this problem most often. Now in these scenarios, the most dependent part of the great saphenous vein will be around the medial malleolus. So what can happen if more amount of blood is getting pooled in this area? Gradually, the red hemoglobin will disintegrate into brown, black, and more amount of brown, black pigment would be seen in this area just beneath the skin, which may give a brownish, blackish pigmentation of the skin in this area, and the skin can even become leathery, which we call as lipodermatosclerosis. Like here what you're seeing, beta, this is the foot area, this is the lower leg, this is the area around the medial malleolus. Because of pooling of blood in this area for a long period of time, there is brownish, blackish discoloration of the skin with leathery appearance of the skin. This is called as lipodermatosclerosis. Gradually, what can happen, beta? If the blood remains pooled here for a long period of time, if the blood remains pooled here in this particular area for a long period of time, what can happen? Because of pooling of blood beneath the skin in the most dependent part around the medial malleolus, this pooling of blood is going to put pressure on the overlying skin, and the overlying skin can ulcerate, and that results in a ulcer, most often seen around the medial malleolus. This is also called as the gatus area between the medial malleolus and from behind, if you go towards the lateral malleolus, that is called as the gatus area, and you can find these ulcers something like this. As you can see, here would be the medial malleolus, and here on the other side will be the lateral malleolus, and you are seeing this ulcer here. This is what is a venous ulcer, right? The MCQ people keep on asking what is the commonest site of venous ulcer. So if you have got the concept nicely, that if the blood remains pooled in the superficial vein, in the great saphenous vein for a long period of time, the most dependent part of the great saphenous vein is around the medial malleolus. And if blood is remaining pooled beneath the skin here for a long period of time, this blood is going to put pressure on the overlying skin, and the overlying skin will ulcerate, leading to this venous ulcer. If this venous ulcer is present for a long period of time, it can even transform into a Marjolin's ulcer. Marjolin's ulcer. Now this, what we are seeing, is a Marjolin's ulcer. This is a high risk of transforming into squamous cell carcinoma. Squamous cell carcinoma. Squamous cell carcinoma is a slow-growing cancer. This squamous cell carcinoma can involve the lymph nodes, and the treatment for these squamous cell carcinomas is surgical excision. Radiotherapy is not usually the preferred treatment for squamous cell carcinomas developing in Marjolin's ulcer. So this is the clinical presentation of varicose veins. Let us take a look what all is written in the workbook, and then we'll see what you as a doctor are supposed to do in these varicose veins. I hope, beta, you have understood this concept nicely. Varicose veins is a disorder of the superficial veins. When the superficial veins become abnormally dilated and tortuous, that is what we call as varicose veins. Most commonly seen in the lower limb. Most commonly they are due to valvular incompetence. And most common valve becoming incompetent is the saphenofemoral valve. Risk factors for damage to these valves: prolonged standing, for example, the traffic policemen, the rickshaw pullers, some teachers of missed coaching institute who keep on standing for the whole day and teach you by standing for the whole day. If there is prolonged pressure on the deep veins, this pressure will be exerted onto the superficial veins, into the valves, and these valves can become incompetent. Pregnancy, माँ बच्चे को 9 महीने तक पेट में रखती है और बच्चा माँ की इंफीरियर वीना केवा के ऊपर 9 महीने तक बैठा रहता है, उस इंफीरियर वीना केवा को दबाते रहता है, जिसकी वजह से नीचे फीमोरल वेन में प्रेशर बढ़ जाता है और ये प्रेशर जो सेफेनोफीमोरल वेल्व है उसको खराब कर देता है और फिर फीमोरल वेन का ब्लड ग्रेट सेफेनस वेन में जाना शुरू हो जाता है. Any pelvic tumor, for example, in the MCQs, they may give you a scenario of tubo-ovarian mass. Tubo-ovarian mass. Progesterone. Progesterone is known to create weakness in the valves and the sphincters. Progesterone causes relaxation of the smooth muscles. Even deep vein thrombosis, beta. Once again, I would like to explain you the concept of deep veins here. Suppose I say, beta, this is the deep vein. Deep veins are deep which are located within the muscles, like in the lower limb, the tibial veins, the popliteal vein, the femoral vein. These are the deep veins. Suppose I say that this here is the great saphenous vein and here is the short saphenous vein. Now, if I say that there is a thrombus developing in the deep vein here, that means blood will not be able to flow upwards easily, so there will be more pressure in the system. And if there is more pressure in the system, then whatever valve is present here, this high pressure in the deep vein will damage this valve and blood will start moving from deep into the superficial vein. So this is how DVT can be linked to varicose veins. Apart from this, there are genetic factors also which can cause this varicose veins. We know if there is valvular incompetence, जब ये valve खराब हो जाएगा, when the patient will be walking, there will be contraction of calf muscles, more pressure on the deep vein, blood from the deep vein starts moving from the deep into the superficial veins. So pressure in the superficial vein will increase, and this is what we call as ambulatory venous hypertension. Ambulatory venous hypertension. Patients can present to us with aching discomfort in the calf or heel. There is high risk of bleeding from these dilated tortuous veins. Various complications what we can see. Venous ulcer can be seen. Lipodermatosclerosis can occur. A venous ulcer most commonly seen around the medial malleolus. Around the medial malleolus. This is called as the Gator's area. Gator's area. This is the area between the two malleoli. This venous ulcer can complicate into Marjolin's ulcer. Marjolin's ulcer, beta, they can also be seen in skin ulcers in burn patients. Skin ulcers in burn patients. There also we can see this Marjolin's ulcer, and this Marjolin's can complicate into squamous cell carcinoma. Squamous cell carcinoma. If we take a look at this squamous cell carcinoma, the squamous cell carcinoma, it is slow growing. Can involve the lymph nodes. And treatment of choice. Treatment of choice is surgery. Radiotherapy is not the treatment of choice. Radiotherapy is not the treatment of choice. So these are the details about the squamous cell carcinoma developing in these Marjolin's ulcer. Once this has been asked that which of the following is not true regarding squamous cell carcinoma developing in Marjolin's ulcer, and they mentioned it is a slow growing, it can involve the lymph nodes, surgery is the treatment of choice, radiotherapy is the treatment of choice. So it is not radiotherapy which is the treatment of choice. Another complication what we talked about is lipodermatosclerosis. This brownish or blackish discoloration of the skin with leathery appearance, what we are seeing, this is called as lipodermatosclerosis. Lipodermatosclerosis. This can be asked as an image-based question also. And in this appearance, what we are seeing here, this looks like a champagne glass, or you can say a champagne bottle. This calf appears somewhat like this. And then there is a glass something like this, and then this is the top. So we can also call this as champagne glass or champagne bottle appearance. Champagne glass or champagne bottle appearance. Herein, depending on how the patient is presenting to us, we can even classify these varicose veins. There is a SEEP classification what we are using. So we'll just try to find some space And let's try to mention about the SEEP classification somewhere. Okay, so we have got some space in this particular area, beta. So what we can do is we can use this space and let us try to see what is this SEEP classification. SEEP classification for varicose veins. The SEEP C for clinical, E for etiology, A for anatomy, and P for pathology. Herein, C1 is just the reticular veins, or we can say C is the clinical beta. So we are just talking about the clinical classification, though this has never been asked in the FMG exams. But there was a question in 2021 in NEET PG exam. So we are just taking a note of it. Clinical classification beta, that is what you as a doctor are seeing in the patient, right? So if you just find thin veins in the lower limbs, just like small telangiectasias. Ectasia means dilatation, right? So that is what is C1. C2 is the classical varicose veins, that is abnormally dilated and tortuous veins. C3 is when they're associated with edema. Varicose veins associated with edema. C4, when we find skin changes. Varicose veins are present along with skin changes, and we can classify the C4 into C4A, this is eczema. C4B, this is lipodermatosclerosis. And C4C is corona phlebectasia. Corona phlebectasia. C5 and C6, they are when venous ulcer is present. When venous ulcer is present. Now, what is the difference between 5 and 6? 5 is when the ulcer is healed, and 6 is when the ulcer is active. Right, beta. So let's try to learn this, beta. C1, reticular veins or telangiectasias. C2, varicose veins. C3, edema. C4, skin changes. And C5, C6, venous ulcer. C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. C5 and C6, venous ulcer. Right? First, let's learn this much. C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. C5 and C6. Just give me a moment. Right. So, just a second. C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. C5 and C6, venous ulcer. Right? Let's do it once again, beta. Let me just remove myself and then let's try to do it. Right. So C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. And C5, C6, venous ulcer. Once again, beta. C1, C2, C3, C4, C5, C6. Right. C1, C2, C3, C4, C5, C6. Perfect. Now, if I remove everything, beta, and let's do it. C1, C2, C3, C4, C5, C6. Very good. C1, C2, C3, C4, C5, C6. Very good. C1, C2, C3, C4, C5, C6. Yes. एक बार फिर से करेंगे बेटा. हाँ. C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. C5, C6, venous ulcer. एक बार फिर से करेंगे बेटा. C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. And C5, C6, venous ulcer. Right, beta? So let's clap for everyone. That's really good. Wonderful. Let's do it once again, beta. C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. C5 and C6, venous ulcer. Right? Now, if we take a look, in C4, A, B, C, A, eczema, B, lipodermatosclerosis, and C, corona. A, eczema, B, lipo, 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 C, corona. And C5, C6, beta, C5 is healed and C6 is active, right? Let's do it once again, beta. C1, reticular veins. C2, varicose veins. C3, edema. C4, skin changes. C4a, eczema. C4b, lipodermatosclerosis. C4c, corona phlebitis. C5, healed venous ulcer. C6, active venous ulcer. Right? Now let's try to close it and then do it once again, beta. Just look at me on the screen. Look at me on the screen. Yes. Can we repeat this, beta? So C1 reticular veins, C2 varicose veins, C3 edema, C4 skin changes, A eczema, B lipo, C corona, C5 C6 venous ulcer, C5 healed, C6 active. Now you have to speak out from your vocal cords, beta. Unless until you are in library, please do speak out, right? C1, C2, C3, C4, C4A, C4B, C4C, C5, C6, C5, C6. Very good. Wonderful. Very good. Let's do it once again, beta. C1, C2, C3, C4, C4A, C4B, C4C, C5, C6, C5, C6. Very good. Right. So we are able to learn this classification to some extent so that we can minimize our time in learning this classification once again. When we are doing it together, Navita, there's a totally different feeling, and the things we tend to learn those things even faster. So I think these small exercises may help you in learning the cramming part also. Chali beta. So what we have discussed till now, very simple story. We know the venous anatomy. There is a superficial venous system, there's a deep venous system, and then there is a connecting system or the perforating veins. Normally, valves are present. Because of these valves, whatever blood comes up, that keeps on moving up and does not go back. Normal individuals, on walking, muscles contract, pressure in the deep vein increase, blood from the deep vein move upward. It cannot go into the superficial veins because there are valves between the deep and superficial veins, and the direction of valve is such that they can allow the blood to move from superficial to deep, but they do not allow the blood to move from deep to superficial. But in those individuals who keep on standing for long periods, or maybe some abdominal masses, pregnancy, tubo-ovarian mass, pelvic tumor, or maybe deep venous thrombosis, or sometimes progesterone or genetic reasons, if these valves become incompetent, like if saphenofemoral valve become incompetent, or saphenopopliteal valve become incompetent, or valves in the perforators become incompetent, then when the person is walking, pressure in the deep vein increasing, and now the blood can move from deep into the superficial vein. When more blood comes into the superficial vein, they become abnormally dilated and tortuous, which we call as varicose veins. Patient can present dilated veins. Any slightest trauma in these dilated veins can lead to bleeding, right? Sometimes, because of pooling of blood around the medial malleolus, around the ankle area, the red hemoglobin will disintegrate into brown-black, which will give a brown-black discoloration of the skin with leathery appearance, which we call as lipodermatosclerosis. And sometimes, when this blood remains pooled around the medial malleolus for a longer period, this pooling of blood is going to put pressure on the overlying skin, and the overlying skin can break and ulcerate, and that is called as a venous ulcer. That is why the commonest site of venous ulcer is the gaiters area. That is the area between the two malleoli, medial and lateral malleolus, right? This venous ulcer can complicate into Marjolin's ulcer, and Marjolin's ulcer can transform into Konsa cancer. Which cancer? Squamous cell carcinoma. These squamous cell carcinomas are slow-growing cancers, can involve the lymph nodes, and treatment of choice is surgery, not radiotherapy. Sometimes there may be a champagne glass or champagne bottle appearance what we see. Right, beta? So this is the story of varicose veins. Now, how as a doctor, we can identify these varicose veins just by looking at the dilated tortuous veins. We can make out that, okay, this is a case of varicose veins. Now, since we know that there can be, like beta in this particular picture, can you see these dilatations here? So this we can call them as reticular veins or telangiectasias. Here you can make out beta how this superficial vein is getting abnormally dilated and tortuous. So this would be varicose veins. That means if this type of image comes to you, this would be C1. If this type of image comes to you, this would be C2. And this beta, I hope we know nicely that if there is lipodermatosclerosis, this will be C4b. And this ulcer, this would be C5 or C6, depending on whether it is healed or active. Right. We can do beta some clinical test to identify which perforator is incompetent, whether it is saphenofemoral or whether it is saphenopopliteal or the other connecting vein perforators, they are incompetent. So we can do some clinical test. They are broadly Trendelenburg test. They are also referred to as tourniquet test. For identification of perforators, we can also do a Fagan's test. So there are some clinical tests beta which we can do and identify which valve is incompetent, right? For example, we can do this tourniquet test. That is a Brody Trendelenburg test. We can identify the saphenofemoral, saphenopopliteal, and the perforator valvular incompetence. We can also do Fagan's test for perforator incompetence. Herein we should note that Perthes test is something which we do in deep vein thrombosis, and Adson's test, which we discussed little earlier, this is done in cases of thoracic outlet syndrome. Thoracic outlet syndrome. This is just to remind about these tests. Now, once we have done the clinical test, then to confirm our clinical findings, which valve is incompetent, we can do a duplex imaging. Artery के लिए क्या कर रहे थे बेटा? Color Doppler. For arteries, we were doing a color Doppler. For veins, we are doing a duplex imaging. What is the difference here? Now, in an ultrasound, there is either a grayscale, that means a black and white, or a B scan ultrasound. And there is a color ultrasound where there is a facility of color flow. Okay? If you add Doppler, that means sound to it, then we start using Doppler word. So color Doppler is a color ultrasound with Doppler added. Why Doppler? Because we are talking about blood flow. So we want to know about the velocity of flow. And velocity of flow we can hear with the sound. So we use the Doppler. Duplex means a combination of black and white ultrasound and Doppler. We don't use color here, right? There is no use of color for veins, right? So, in duplex, it is a black and white, that is a grayscale or a B scan ultrasound, plus there is a Doppler added. That is duplex. Now, when we are doing a duplex ultrasound or when we are doing a duplex imaging beta, sometimes we can see something like this, what you're seeing on the screen. Now, this what you're seeing on the screen, if I remove myself beta, this looks somewhat like a Mickey Mouse. This looks somewhat like a Mickey Mouse. Can you appreciate this Mickey Mouse here, beta? Something like this. This is, the eyes are not seen here, and the smiley is also not seen here, right? Okay, now this is what we refer to as Mickey Mouse sign. Actually speaking, beta, if we try to focus that how a normal ultrasound for these veins look like, actually this what you're seeing is the common femoral vein, and this is the right common femoral vein. So this is something which is normally seen. And here there is a great saphenous vein. So normal appearance is something like this. And you know there is a valve at the saphenofemoral junction. So this will allow the blood to move only in this direction. But whenever this valve is going to become incompetent, then the blood will start moving in this direction. And when the blood starts moving in this direction, then this great saphenous vein, what you're seeing here like this will become somewhat like this. That is why this is what you are seeing in incompetent saphenofemoral valve, and that is what is giving us a Mickey Mouse sign. So if there is a saphenofemoral incompetence on duplex imaging, we can see a Mickey Mouse sign. Mickey Mouse sign. Now, in the treatment for these varicose veins, what we can do, beta? Let us just try to imagine the situation. Suppose this is the superficial vein. Let me bring myself. Yeah. Suppose I draw it here. Suppose this is the great saphenous vein, which is dilated and tortuous, and this is connected to the femoral vein. And femoral vein, suppose, is somewhat like this. We know that patient is having problems because there is pooling of blood in this great saphenous vein, and we don't want this pooling of blood. If the patient comes to us in early stages, then we just advise some lifestyle modification. Like, we know if this patient keeps on standing for long periods, if the patient is standing for long periods, beta, what will happen? The blood will not be able to flow nicely in this direction. ऐसे direction में blood आसानी से नहीं जा पा रहा है ना? So there is pooling of blood here, there's pooling of blood here, there's pooling of blood here. So if this valve is incompetent, more blood would be coming into this, and the patient will have more discomfort. So we ask the patient not to keep on standing for long periods. Otherwise, he will have more discomfort. We prefer that if the patient is lying supine, and if we ask the patient to raise the upper limb or raise the lower limb, for example, if I try to bring this picture here, now beta G, if we just take this picture, now let me create a duplicate here, and now let me right. Fine. Now let us just try to understand this story. Right, beta. Now suppose in this particular image, suppose I say that here is the deep vein, and here is lying the dilated tortuous vein. Right? Now, if this patient is standing for long periods, there will be more pooling of blood in this. There will be more pooling of blood in this, more discomfort. If we ask this patient to lie down, if we ask this patient to lie down, now what is going to happen? Now we can see that on lying down, what is happening? There will be more flow going towards the heart. And when this patient is lying down, we can advise this patient to put some pillow so that this can be raised a bit. Now, if you raise this a bit, what is going to happen, beta? There will be more flow going towards the heart. That means there will be less pooling of blood in the superficial vein. So there will be less symptoms, less discomfort in this patient, reduced risk of complications in this patient, right? So in venous disorders, lymphatic disorders, because their job is to bring the blood or fluid back towards the heart, raising the limb facilitates the flow towards the heart and patient feels relieved. But in arterial problems, artery has to bring the blood down. Raising the limb in arterial obstruction will give more difficulty to the patient, and it will be more difficult to supply blood into this area. So arterial obstruction patients on limb elevation, the pain will worsen, right? So arterial obstruction patients, the patient feels more comfortable if the patient is keeping the limb down. But venous and lymphatic disorder patients, they'll feel more comfortable if the limb is elevated. Right, beta? I hope this is absolutely clear, right? Fine. Okay, so in the initial stages, what we are doing is we are just trying to modify the lifestyle. Conservative treatment, lifestyle modification, avoid prolonged standing, limb elevation. We can advise elastic compression stockings. Now, if you give elastic compression stockings, that means if suppose the patient is wearing these elastic compression stockings, what will be the advantage to this patient? Suppose the patient is standing like this, right? Now, if you advise compression, if you just try to put pressure, compression stockings are just like these socks, right? They are made of a different material. They exert uniform pressure. The patient is wearing those compression stockings. So because of those stockings, there is pressure from the outside. And this pressure from outside is not allowing the blood to come easily from deep to superficial. There is an external pressure on the superficial veins, which is forcing the blood in the superficial veins to go towards the deep veins, right? So that is how elastic compression stockings will not allow pooling of blood in the superficial veins. So the chances of complications of varicose veins will be less. That is the role of elastic compression stockings, right? Fine. In late stages, beta, when complications have developed because of these varicose veins, then we have to destroy these varicose veins. In order to destroy these varicose veins, we can use either some sclerosing agents, or we can destroy these varicose veins by radiofrequency ablation, or by laser ablation, or we can do surgery and destroy these veins. For sclerotherapy, what we can do is now suppose the patient is lying supine like this. Okay. In this patient, what we can do is we can make a small hole in the vein here, and then we can put some catheter into this dilated vein and put sclerosing agent. Sclerosing agent is something which is commonly used in vascular surgery to destroy especially the dilated veins. We are not only using sclerotherapy here in varicose veins, but we also use in the treatment of hemorrhoids, varicocele, esophageal varices, and so on. जहाँ जहाँ भी बॉडी में वेन्स एबनॉर्मली डायलेट और टॉर्चर्स होंगी, वहाँ पे हम ये स्क्लेरोथेरेपी यूज करके उन वेन्स को बर्बाद कर सकते हैं, राइट? सो हियर वी कैन मेक अ स्मॉल ओपनिंग हियर, and then through this we'll pass a catheter which would be going into this dilated tortuous vein, and then we'll push the sclerosing agent, and then we keep on putting the sclerosing agent and we withdraw this catheter. So the entire vein, we are pushing the sclerosing agent all over the vein and we are removing the catheter along with it. So this is going to cause sclerosis of the vein and the vein will be destroyed. Now there won't be any pooling of blood and the patient's complications or patient symptoms will go off. We can use various sclerosing agents. For example, we can use foam, we can use phenol in almond oil, we can use ethanol amine oleate, we can use sodium tetradecyl sulfate, we can use tetracycline, we can use polidocanol, which is marketed by the trade name of Escarol. We can use picibanil, which is marketed by the name OK432. So these are various sclerosing agents what we can use to destroy the veins, right? Any of these sclerosing agents can be used at other places also, whether it is varicocele, esophageal varices or hemorrhoids. Like in hemorrhoids beta, we'll be writing about this phenol in almond oil. In varicocele, we'll be writing this polidocanol escarol. In cystic hygroma, which is a lymphatic swelling, we'll be writing this picibanil or OK432. Right? So these are various things which can be used. Radio frequency ablation, the same procedure beta. What we can do is, if we have to destroy this vein by radio frequency or laser, we are going to put a catheter from here. Suppose a laser fiber is put into the vein under ultrasound guidance. We take this laser fiber right up to this place. We press a button so that laser energy is released, and then we just withdraw this wire and keep firing the laser energy all along this vein. And that is how we can destroy this vein by laser. So that is a radio frequency ablation or laser ablation. We can even do surgical removal of these varicose veins. For surgical removal, what we have to do is, we have to make an incision in this particular area, that is just beneath the groin crease in the upper thigh. यहाँ पे एक चीरा लगाएंगे बेटा. We'll go into this area. We'll dissect this saphenofemoral junction, and then what we'll do is, we'll ligate. We'll put a suture here. we ligate this area. Now this area beta, we ligate this great saphenous vein flush with the femoral vein, as close as possible with the femoral vein. We don't put this pinky ligature here. If suppose you are putting a pinky ligature here, then what can happen beta? This part of the vein will remain patent and blood from the deep vein will be coming right up to this point, and this can lead to swelling in this area. So instead of ligating a little far from the femoral vein, it is recommended to ligate this great saphenous vein as close to the femoral vein as possible, because now there is nothing where the blood from the deep vein can go. Once we ligate this great saphenous vein here, then we make a hole in the great saphenous vein in this area. Suppose I use a white color now. I make a hole in this area. Okay, I make a hole in this area and then I put a wire. I just put a wire into the vein. This wire goes into the great saphenous vein right up to the knee area. This wire has gone into the vein. I'll use a black color for the wire beta because I think it is not clearly visible. So I'm just putting a wire into the great saphenous vein right up to this particular area. Okay. Then I will tie the great saphenous vein in the wire. I tie the great saphenous vein in the wire. The wire is going from here, right? Now what I'll do, I'll pull this wire. When I'm pulling this wire, because the great saphenous vein is tied with this wire, this entire great saphenous vein will be stripped off. Stripping of this great saphenous vein. We are stripping the great saphenous vein. That is how we can remove this great saphenous vein. Please remember beta, we should not do the stripping below the knee level. नीचे की वेन को नहीं निकालना है, because there is a nerve which is lying very close to the great saphenous vein. Below the knee level, there is a saphenous nerve which is lying very close to the great saphenous vein. If we try to remove the great saphenous vein from this level also, then there is high risk of injury to this nerve. So to avoid risk of injury to the saphenous nerve, we don't do stripping of the great saphenous vein below the knee. We just do the stripping right up to the knee level. Just remove this segment of the vein. Same way beta, if suppose we are doing surgery for short saphenous vein. Now short saphenous vein is on the lateral side. Suppose I say that we are doing surgery for short saphenous vein. Then short saphenous vein is opening into the popliteal vein. Here we just do the ligation. We don't strip off the short saphenous vein, because in this area, very close to the short saphenous vein lie the sural nerve. So if we try to remove the short saphenous vein, there is risk of injury to the sural nerve. So we don't remove these veins below the knee level, right? That is how we are treating these varicose veins by surgery. The name of the operation what we are doing for varicose veins is Trendelenburg operation. This Trendelenburg operation beta, it is flush ligation. Flush means as close as possible. बिल्कुल चिपका के. Flush ligation of great saphenous vein with the femoral vein. Plus we do stripping of the great saphenous vein, and the name of the stripper is Mayo's vein stripper. The name of the stripper is Mayo's vein stripper. In clinical practice beta, the actual scenario I'll tell you, in Indian scenario, sometimes suppose you are doing this varicose vein surgery and you don't have this Mayo's vein stripper inside the operation theatre, and the staff nurse of the operation theatre also does not know that you need that stripper. So you are in the middle of the operation and now you ask the sister, give me the Mayo stripper, And sister says, no, sir, we don't have this Mayo stripper in the OT. Now, in these cases, the attendant who is standing outside the operation theater, we ask that attendant to bring a clutch wire or a gear wire of a two-wheeler. जो अपनी स्कूटी होती है ना बेटा, स्कूटी, or maybe a scooter, you can say, that is having a clutch wire. If you have seen, that's a long wire. One end is in this clutch in the hand, and the other end of the wire is there in the machine, machine behind. Right? So we can just ask the patient to bring that clutch wire, and instead of using that Mayo's vein stripper, we can use this clutch wire and try to strip off the great saphenous vein. Right, beta? Sometimes in perforator incompetence. Now, perforators, beta, perforators are the connecting veins. Like in anatomy, we read that there are perforators 3 to 4 at the level of ankle. There are 2 perforators below the knee level, and 1 perforator is there in the mid-thigh level. Right. So sometimes the valves in the perforators become weak. In these cases, just imagine, beta, that if we focus on one of the perforators, just one of the there are valves in this, and normally the direction of valve is something like this. So blood moves from superficial into deep normally. But when this valve has become incompetent, then blood will start moving in the opposite direction. That means now the blood is moving in this direction, and more blood is coming into this. Right? Now in these cases, beta, ideally we should ligate these perforators. So if you have to do open surgery for ligation of these perforators, since there are numerous perforators in the leg, so you might have to make multiple incisions in the leg to ligate these multiple perforators. Varicose vein problem is common in females. Just imagine Western countries, summer months. If you have made multiple incisions, there will be multiple scars in this area. And this is not cosmetically acceptable to the female. So instead of doing an open surgery for these perforators, now we are doing an endoscopic surgery. Just by making 2 incisions in the leg, we can ligate all the perforators endoscopically. And that is what we prefer nowadays. That is called as SEPS, subfacial endoscopic perforator surgery. So if there are perforator incompetence, then what we are doing is SEPS. SEPS is subfacial endoscopic perforator surgery. Subfacial endoscopic perforator surgery. Right? Okay. So this is the whole story about varicose veins. Now there is another pathology in this veins in the lower limb, commonly, that is a deep vein thrombosis. Abhi deep vein thrombosis, if we just try to understand, Now we know there are deep veins, the tibial veins, the soleal veins, the popliteal vein, the femoral vein. The direction of blood flow like this. If suppose this patient is lying supine for long periods, then what can happen? If this patient suppose is having some problem, maybe suppose a femur fracture is there, or maybe he's having paraplegia, or maybe he's admitted in ICU for long periods, so he's lying supine. Now we can very well understand, beta, if this patient would have been standing, then because he's walking, his muscles would have been contracting, and those contraction of the muscles would have really favored the blood moving upwards towards the heart, right? But if this patient is lying like this for long periods, then there will be slowing of circulation. Suppose somebody is taking a long flight from San Francisco to New Delhi, which might take 16 hours. So if you are sitting in this flight for 16 hours and you're not moving your limb, then the muscles are not contracting. So they're not putting much pressure on the deep vein, because of which the blood is not moving upwards easily. There is a risk of slowing of the circulation. Because of slowing of the circulation, there is a pooling of blood. And in pathology, there is a virtuous triad, beta. This virtuous triad in pathology: endothelial injury, stasis, and hypercoagulability, right? Whenever there is stasis, that is slowing of circulation, there is a chance of thrombus formation. And because of this, what can happen? A thrombus can form into this deep vein. If a thrombus forms into the deep vein, which is usually the calf vein or the soleal vein, this is what we call as DVT, deep vein thrombosis. We can understand, beta, the blood will not be able to move upwards, so the blood will be getting pulled down into this vein. This blood is getting pulled here in this. There will be stasis of blood in this area. And whenever there is any stasis, it is an open invitation for the bacteria. It is something which is a simple common sense. If you just compare the rivers with the ponds, अगर आप नदियों को देखें और तालाबों को देखें, in the rivers, the water is freely flowing, while in ponds, the water is stagnant. नदियों में अगर आप देखते हैं बेटा, तो बहता हुआ पानी होता है और तालाबों में पानी रुका हुआ होता है. What is more dirty, rivers or ponds? कौन सा ज्यादा गंदा होता है, नदियां या तालाब? Obviously, where the water is stagnant, जहां भी पानी रुका होगा, there it will be more dirty. वहां पे गंदगी ज्यादा होगी. The same concept applies everywhere inside our body, beta. Whenever we talk about traffic jam situations here and there is stasis. And stasis is an open invitation for the bacteria, and the bacterial party will start in this area. Once the bacterial party starts, this is going to cause acute inflammation. And because of this acute inflammation, the signs of acute inflammation: Reubert tumor, Kaller, Dollar, Arvind, Reubert tumor, Kaller, Dollar from Volgograd. Arvind from Volgograd, he requested about this Reubert tumor, Kaller, Dollar. I hope you're listening, Arvind. So what is going to happen in this area? This entire area is going to get inflamed. And now the patient would present with signs of acute inflammation in this area. this entire area would be red, swollen, raised temperature, and there will be severe pain in this area. If you try to elicit some signs, maybe if you try to dorsiflex the patient's foot, something like this, just imagine there is acute inflammation in this area, and now if you try to dorsiflex the foot, the muscles of this area will resist any movement. This is acutely inflamed beta. Patient is having severe pain. ये पूरा लाल सूजा हुआ है गुस्से से एकदम. अगर कोई भी इस इलाके को छेड़ने की कोशिश करेगा तो पेशेंट को बहुत तकलीफ होगी. ऐसे ही अगर हम मान लीजिए इसके पैर को ऐसे डॉर्सीफ्लेक्स करते हैं तो यहाँ की मसल्स करने नहीं देंगी. Resistance by the calf muscles in dorsiflexion of the foot is what we call as Hohenstein, 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 Hohenstein. Now, Hohenstein has been asked twice in the last 5 exams. Hohenstein is seen in DVT, deep vein thrombosis, and that is resistance by the calf muscles to dorsiflexion of the foot. There is another sign what we can elicit in DVT. If you try to squeeze the calf muscles in this patient, patient will have severe pain. So pain on squeezing the calf muscles, that is called as Moses sign. Now, both Hohenstein and Moses sign are not advised. They have become obsolete because this area is acutely inflamed. If we try to chedo this area, if we try to manipulate this area, there is a risk that this yellow thrombus, what you're seeing here, this yellow thrombus can migrate and it can go upwards, it can go into the inferior vena cava, it can go into the right atrium, right ventricle, pulmonary artery, lungs, and pulmonary embolism can occur. I repeat, beta, nowadays, if the patient is having DVT, we do not want to manipulate this area. If we try to do a dorsiflexion of the foot, if we try to squeeze the calf muscle, there is a risk that this thrombus can migrate up. And here, it is going into the femoral, the external iliac, the common iliac, the inferior vena cava, right atrium, right ventricle, pulmonary artery, lungs. So this can lead to pulmonary embolism. That is why we don't do this Hohenstein and Moses sign. We should take care of another sign, that is Hammond's sign, which is seen. Hammond's sign is seen in Bohr-Havi syndrome, which we'll read in adult surgical problems. Okay? Fine. Now, what should be done in the treatment? Though this area is acutely inflamed, we can do a duplex imaging to check whether there is any thrombus in the deep vein or not. The best investigation for a vein is a ascending venography. We can put the contrast in the vein and see, just like angiography, but that is invasive. So that is not the recommended, but yes, that would be the best. Okay. So generally we are doing a duplex imaging. We come to know there is a thrombus here. We don't want all this stuff here. We want this thrombus to be dissolved. First thing to be done is low molecular weight heparin. And then we put the patient on warfarin, anticoagulants. And this helps in dissolution of the thrombus. Right? So this oral warfarin is given for a period of 3 months. If by chance this patient has a tendency to develop DVT again and again, अगर बार बार DVT होने का चांस होता है, then we put a filter in the inferior vena cava. Inferior vena cava is here in the abdomen, right? So if the patient is developing this DVT of on and on, again and again, then we just go inside and put a filter in the inferior vena cava so that the thrombus in the leg cannot cross the filter, cannot cause pulmonary embolism. Right. So this is the story about the deep vein thrombosis. Now we'll have to do something for this. Thrombosis, it is the calf vein or the soleal vein. Calf vein or the soleal vein. Most common cause is prolonged immobilization. Prolonged immobilization. जो लोग ज्यादा समय तक लेटे रहते हैं, कारण कुछ भी हो, reason may be any, prolonged immobilization will increase the risk of slowing of the circulation, stasis, more chances of thrombus formation. This can be seen in ICU patient, paraplegia patient, multiple sclerosis patient, bedridden patient, lower limb fracture, long haul flights. You might have seen people beta who are taking long flights. They do exercise inside the flight, or you may find a lot of people doing these exercises at the bay. Virtuous triad of thrombosis. This is a pathology triad. Endothelial injury, stasis or turbulence, and hypercoagulability. Because of traffic jam in the vein, we know there is pooling of blood. Open invitation for the bacterial party, Ruber, tumor, Kaller, and Dollar. Homan sign, this is resistance by calf to dorsiflexion of foot. Resistance by calf to dorsiflexion of foot. Please do not confuse this with Hammond sign. Hammond sign is something which is seen in Bohr-Havi syndrome, which we'll be discussing in Bohr-Havi adult surgical problems. Moses sign. This is calf pain on squeezing the calf muscles. These signs have become obsolete and they should not be done because they carry the risk of migration of the thrombus upwards and can lead to pulmonary embolization. Investigation of choice for veins is duplex imaging. Duplex imaging. However, gold standard but not done. Gold standard investigation for veins but not done is ascending venography. Ascending venography. Treatment for these DVTs, low molecular weight heparin. We can add oral warfarin for 3 months. If the patient is having recurrent deep vein thrombosis, then we can use IVC filter. Recurrent DVTs, we can use IVC filter. Right, beta. So this is all about the venous disorders. And now let us take a look at the lymphatic disorders, which is a very, very small story. we know beta that inside our body God has given us the lymphatic channels also. Whatever cellular metabolism is taking place inside a body, let me stand up and explain this nicely to you. Now, if we take a look at the various lymphatics inside a body, cellular metabolism, the fluid is continuously leaking out into the interstitial spaces. The fluid is continuously getting formed and removed. So some amount of fluid is always there in the interstitial space, and there are lymphatic channels. The job of these lymphatic channels is to drain that interstitial fluid, whether it is the lower limb or it is all over the upper limbs. What happens? These lymphatic channels, they are bringing this lymph through the lymph nodes upwards into the lymphatic channel, and ultimately this lymphatic channel is opening into the vein that is at the junction of subclavian and the jugular vein. So the lymph is getting poured into the vein, and from there subclavian vein going into the superior vena cava and then into the right atrium, right ventricle, lungs. This is how the circulation happens for the lymph, right? If suppose there is any traffic jam in the lymphatic channel, for example, the commonest cause in India is filariasis, Eastern UP and Bihar. What happens, beta? The parasite, the Wuchereria bancrofti, what that parasite can cause, that can create traffic jam in the lymphatics. Now suppose my lymphatic channels, which are traveling like this, if the parasite comes here and creates traffic jam in those channels, what will happen? The lymph will not be able to move upwards. So the lymph is going to get collected down, and this will cause swelling of the limb. That is what we call as lymphedema. Sometimes, beta, we find these lymphedemas in various cancers, like breast cancer, beta. Breast is drained by the axillary lymph nodes. Sometimes the cancer cells, they go into the axillary lymph nodes, create a traffic jam in the axillary lymph nodes, right? Now, whatever lymph is drained from the arm, that lymph is not able to go up. So all the lymph will get collected in this, and this will cause lymphedema. Or suppose you are doing surgery for breast cancer, where you have removed the patient's breast, plus you have removed the axillary lymph nodes. That means you have destroyed the axillary lymph nodes, beta. So now how will the lymph from this will go? No. So all the lymph will get pooled here, lymphedema. Or suppose, beta, you have given radiotherapy to the axilla to destroy the lymph nodes in cancer. Whatever is the reason, whether these lymph nodes are blocked by cancer or removed by surgeon or destroyed by radiation, if these lymph nodes are destroyed, the lymph from the upper limb will not be able to move towards the heart. All the lymph will get collected here, and that is lymphedema. This is something what we see commonly in our clinical practice. Sometimes rare situations, if by chance God has not formed the lymphatic channels, if I say that God has not formed the lymphatic channels, now because God has not formed the lymphatic channels, so what will happen? The lymph is not going to get drained. If lymphedema is because of hypoplasia of lymphatic channels, that means God has not formed the lymphatic channels properly, then we call this lymphedema as primary. But if this lymphedema is because of some diseases like filariasis, or because of cancer, or because of surgical removal of lymph nodes, or because of radiotherapeutic destruction of lymph nodes, Such type of lymphedemas are called as secondary lymphedemas. Overall, what is common? Secondary lymphedema. Overall, commonest cause of lymphedema, filariasis. Overall, most common cause of upper limb lymphedema, breast cancer. Primary lymphedema, where God has not formed the lymphatic channels, depending on the age of presentation of the patient. If suppose a lot of lymphatic channels are not formed, then this patient may present with lymphedema very early in life. If the patient comes to you below 2 years of age with lymphedema, this is called as lymphedema congenita or Milroy's disease. If suppose moderate amount of lymphatic channels are present in the patient, then patient may not present immediately after birth. If the patient comes to you between 2 years of age to 35 years of age, then we call it as lymphedema precox or Meeks disease. If suppose only very little amount of lymphatic channels are not formed, the patient may present to us after 35 years of age, and that is called as lymphedema tarda. Whatever is the cause, if the patient is having lymphedema, if lymph has got collected, we want this lymph to move towards the heart. Unfortunately, we do not have good treatment options. Just few things, like we don't want the patient to keep the limb down, dependent. We want the patient to keep the limb up, raised. We promote manual massaging, so that by manual massaging we are trying to push this limb towards the heart. We can use pneumatic compression devices, just like the BP cuff beta you have seen, na? BP cuff, we tie that BP cuff here, we generate the pressure. So nowadays we have got those pneumatic compression devices which can be applied all over the limb. So BP cuff, just imagine all over the limb, and there is a machine which is continuously generating pressure in that. So lymph is continuously moving towards the heart. Pneumatic compression devices can be used. Nowadays, when we are doing operations, and suppose some operation is going for long period, suppose maybe 2 hours, 4 hours, 6 hours, 8 hours, then also the patient is lying supine on the operation table for 8 hours. Patient is under general anesthesia. How can the patient move his limbs? So in these patients also, Bikta, what we can do, we can put those pneumatic compression devices in the lower limb, and they are connected to a machine which keeps on generating pressure, so that whatever lymph is getting collected, that lymph is continuously moving up towards the heart, right? This is how we manage these lymphedemas. Surgical interventions by creating some shunts and diverting lymph into the veins in the peripheries, the results are not very encouraging. Now let's see what all is written here. Lymphedema is simply accumulation of interstitial fluid. In lower limbs, we have seen that more than 4.5 liters of fluid is getting collected usually to present as lymphedema. Most common lymphedema is secondary lymphedema. Most common cause is filariasis. This is more common in eastern UP and Bihar in our country. Here only you can make a note. Most common cause of upper limb lymphedema is post mastectomy for breast cancer. The commonest surgery done for breast cancer, beta, that is a modified radical mastectomy, where we remove the breast and the axillary lymph nodes. Wherever you are removing the axillary lymph nodes, there will be chances of patient developing lymphedema in the upper limb. These lymphedemas, as we were talking about, we can classify these lymphedemas into primary and secondary. Primary, beta, when God has not formed the lymphatic channels properly, depending on at what age the patient is coming to us, we can classify these primary lymphedemas into congenita, precox, and tarda. If the patient comes to you less than 2 years, it is congenita, 2 to 35 years, precox, more than 35 years, tarda. Congenita is called as Milroy's disease. Precox is called as Meek's disease. Most common out of these three is precox. Overall, most common is secondary lymphedema. That is due to filariasis, cancers, removal of lymph nodes by surgery, or radiotherapeutic destruction of the lymph nodes. Chronic filarial lymphedema can lead to elephantiasis. These are just the images, beta. Just by looking at this image, it is not practically possible for us to tell whether it is primary or secondary, but this is an image taken from one of the patient who was diagnosed later on investigation as primary lymphedema. So this, I hope you can nicely see how this huge swelling is seen. That is the collection of lymph here. This lady is a post-mastectomy upper limb lymphedema. She had breast cancer, beta, and she had involvement of axillary lymph nodes also. So her surgery has been done where breast has been removed and axillary lymph nodes have been removed. And now, since there are no axillary lymph nodes, the lymph from this upper limb is not able to drain to the heart. So all this lymph is getting collected in this area, and this is causing huge swelling of the upper limb. In chronic cases, sometimes long-standing cases, even fibrosis occurs, and here you can see how fibrotic we are seeing. Right? This is a chronic lymphedema, also called as elephantiasis. In the treatment for these lymphedemas, we can do a manual lymphatic drainage, that is massaging. We can use pneumatic compression devices. Results of surgery are not very encouraging. Like nodovenous shunts, the results are poor. So this is what we are commonly doing for management of lymphedema. So this is all about the story of vascular surgery. Here in Vita, what we'll do is we'll take a very short break and we'll come back in 10 minutes or maybe 7 to 8 minutes, and we'll revise the entire vascular surgery, and then we'll call it off for the afternoon session. Actually, there is some urgent work which I'm supposed to do at around 3 o'clock in the afternoon, and it will take some time for travel as well. So I'm not able to keep the class in continuation. Most likely I should be back by 4:30, and we should be able to start by 4:30. If there are any changes there, I'll update you with any changes, right? So here we are taking a very short break, and then we'll come back and revise the entire vascular surgery in 15 to 20 minutes, right? Okay, so we'll be back at 1:20 p.m. for revision. Right, beta. So now let's have a quick revision of vascular surgery, the entire vascular surgery. First, we'll revise with the workbook and then without the workbook. Okay. Right. So herein, what we have discussed or what we have talked about in vascular surgery, we have talked about the story of artery, veins, and lymphatics. In arteries, we talked about gradual arterial obstruction, sudden arterial obstruction, AV fistula, and aneurysm. Veins, we talked about superficial veins, varicose veins, deep vein thrombosis. And lymphatics, we talked about lymphedema, the primary and secondary lymphedemas. In arterial obstruction, gradual arterial obstruction, the commonest cause is atherosclerosis. However, Burgess disease, thromboangiitis obliterans can also be a cause of gradual arterial obstruction. In atherosclerosis, when the atheromatous plaque is getting deposited in the intima of the artery, the lumen may be getting compromised. Initially, in the beginning, the patient does not have any problem at rest. Suppose we imagine the femoral artery intimal plaque developing. When the patient is exercising, for example, when the patient is walking, at that point of time, the demand in the lower limb will increase. The most bulky area, most working area in the lower limb would be the calf muscles. So maximum demand will be by the calf muscles, and patient may start experiencing pain in the calf on walking a certain distance. The distance which the patient is able to walk without any discomfort is called as claudication distance. This calf pain on walking may be improved on further walking due to washout of substance P. This is Boyd's 1. This calf pain on walking may not be so severe and patient may continue to walk with pain. This is Boyd's 2. Gradually, as the obstruction is increasing, the calf pain on walking may become so severe that now patient cannot walk any further and patient has to take rest. This is Boyd 3. Gradually, as the obstruction becomes more severe, the lumen gets more narrow, the distal supply gets more compromised, and then the patient will start experiencing rest pain in the most distal part, that is the foot. So rest pain is felt in the foot. This is Boyd 4. Gradually, as the obstruction is increasing, supply decreasing, the foot may become cold, numb, and may show paresthesia. This indicates moderate to severe arterial insufficiency. Gradually, the distal part in the foot may develop pregangrene, that is rest pain, color changes, hyperesthesia with or without skin ulcerations, and finally the patient can land up in gangrene. You as a doctor, patient can come to you at any of these stages. Most important in peripheral vascular disease is to examine the pulses, the femoral, popliteal, anterior tibial, posterior tibial, and dorsalis pedis. Femoral 2 cm below the mid-inguinal point. Popliteal is the most difficult to feel because it is felt in the prone position. It is in the popliteal fossa. There is no bony prominence near it and it is deep. Anterior tibial can be felt next to the tendon of extensor hallucis longus. Posterior tibial can be felt between the posterior border of medial malleolus and the Achilles tendon. Best felt at inversion of foot, and dorsalis pedis in the proximal half of the first metatarsal space. Whenever there is a traffic jam, distal to the obstruction, the blood flow will be less, the pulse will be low volume, feeble or absent. Proximal to the traffic jam, the pulse will be high volume. Sometimes, if the patient has developed collaterals around the obstruction, we may feel the distal pulses to be normal when the patient has come to us. That is because the blood is getting diverted through the collaterals. But if the patient complains of ischemic symptoms, we can ask the patient to walk in the hospital corridor. On exercise, the collaterals may not be that wide to provide the blood now when the demand has increased, and at this time the distal pulses may disappear. Again, we ask the patient to take rest. Again, the blood starts coming through the collaterals and the distal pulses reappear. Disappearing pulse is because of collaterals. On auscultation, if we hear a whoosh type of sound over the artery, it simply indicates turbulence inside. Probably there is a distal stenosis or obstruction. We can measure the ankle brachial pressure index. This is the instrument what we use to measure the ankle brachial pressure index, the systolic pressure at the ankle compared with systolic pressure at the arm. Normally 1.1 plus minus 0.2, but if there is a traffic jam in the femoral artery, the distal supply would be getting less, so pressure at the ankle would be going down. If this ratio is less than 0.9, intermittent claudication, less than 0.5, rest pain, 0.3, critical limb ischemia, and 0.1, gangrene. This is something which is crucial for us in clinical examination. We make the clinical diagnosis, what is the site of traffic jam. We can confirm the clinical findings by doing a color Doppler. Angiography, because it is invasive, is not the preferred modality. We can do a Fontaine's classifications to grade the severity of arterial obstruction. Grade 1, no symptoms. Grade 2, intermittent claudication, which can be A and B, mild or moderate. Grade 3, rest pain. Grade 4, gangrene. We need to treat this patient, and we need to increase the distal blood supply to treat the symptoms. For doing this, for increasing the distal supply, we can advise lifestyle modification, medicines, angioplasty, and bypass surgery or lumbar sympathectomy. Lifestyle modification is very important. We ask the patient to stop smoking, reduce weight, brisk walk 40 minutes in the morning and 40 minutes in the evening, dietary modification. If the patient follows the advice, there is spontaneous development of good collaterals in 6 months' time and nothing else is required. But since patients can't afford to stop smoking, the patient keeps on coming to us with ischemic symptoms. We can advise some medicines like vasodilators, cilostazol, oxypentyphylline. We can advise antiplatelets like aspirin for long-term use, clopidogrel for short-term use. We can advise statins. We can do angioplasty to dilate the stenosis site in the vessel, and we can do a stenting. Drug-coated stents, sirolimus-coated stents is what we are using commonly. And catheter which we are using in vascular surgery is the Fogarty catheter. When we are doing this angioplasty for coronaries, we call it as PTCA, percutaneous transluminal coronary angioplasty. Another option in the treatment is bypass surgery, where we can create a bypass graft around the obstruction. This can be taken from inside the body or can be bought from the market. From inside the body, autologous; from the market, synthetic. Autologous grafts can be arterial or venous. Arterial will be more powerful, will have long-term patency. We use internal mammary artery commonly, the left and right. We can use gastroepiploic artery. We can even use great saphenous vein. In synthetic grafts, we can either use textile or non-textile. Textile, Dacron, woven, knitted, woven is better. Non-textile, PTFE, polytetrafluoroethylene. Most common cause of early graft failure is faulty technique, late graft failure, graft occlusion, graft infection, Staph aureus. Depending on what is the site of obstruction, suprainguinal, aortoiliac, we prefer Dacron. Inguinal level obstruction, iliofemoral, we prefer doing angioplasty. And infrainguinal femoropopliteal, we do a great saphenous vein bypass graft. Most common peripheral bypass surgery done is femoropopliteal bypass. Sometimes when we are not able to do angioplasty or bypass surgery, if there is a disease of small to medium-sized vessels like Burgess disease, patient keeps on presenting with rest pain, patient is not ready to quit smoking, patient is not able to form good collaterals around the obstruction, in these cases, to relieve the rest pain, we can do lumbar sympathectomy, where we remove the first, second, third, fourth lumbar sympathetic ganglia. This causes dilatation of arterioles in the foot, which steal blood from the calf. So calf blood moves towards the foot, more blood coming in the foot, foot pain, rest pain is relieved. So lumbar sympathectomy is indicated in rest pain. But since the calf blood is going towards the foot, calf blood is decreasing. If the patient had calf pain, that is intermittent claudication, this will increase. So lumbar sympathectomy should not be done in intermittent claudication. If the patient has developed gangrene, then we have to do amputation. Burgess disease is actually thrombosis thrombophlebitis of small to medium-sized vessels associated with Raynaud's syndrome. Burgess is seen only in those patients who use the tobacco. Now, this can be either in the form of smoking or any form of tobacco use. Any form of tobacco use. Usually seen below 45 years of age, less than 30 years of age. More common in males, 95% are males. Usually the lower limbs. Burgess can involve the artery, vein and nerves, but does not involve the lymphatics. Olin's criteria can be used, and majority of these patients come to us with rest pain. In the treatment, mainstay of treatment is lifestyle modification, cigarettes or legs. We can use some medicines like vasodilators, cilostazol, oxypentyphylline, antiplatelets, aspirin, clopidogrel. We can rarely do lumbar sympathectomy to relieve the rest pain. And in cases of gangrene, we have to do amputation. Raynaud's disease is an interesting disease which is just a spasm of arterioles on cold exposure, maybe due to hypersensitivity, commonly seen in young females in the upper limbs. Since it is a problem of the arterioles and not the arteries, the pulses are normal. Primary and secondary Raynaud's. Primary when it is not associated with any other disease. Secondary when it is associated with some other disease, maybe SLE, rheumatoid arthritis, scleroderma, or thoracic outlet syndrome, cervical rib. As soon as the lady dips her hand in cold water, there is spasm of the arterioles and the pulse space becomes white. Stagnation of blood makes it blue, and on rewarming, the arterioles dilate again and the blood reappears, so it becomes red. Characteristic sequence of color changes in Raynaud's, white, blue, red, is called as Raynaud's phenomena. In the treatment, we advise lifestyle modification, avoid cold exposure, wear warm clothing and gloves. We can give medicines, calcium channel blockers and nitrates, and rarely we do cervical sympathectomy. Sudden arterial obstruction or embolism, this is acute limb ischemia, where there is a sudden traffic jam of the artery by an embolus. Most commonly, these emboli originate from mural thrombi from the heart, like in subacute bacterial endocarditis. If there are vegetations sitting on the heart valve and the heart fibrillates, these vegetations are lifted off from the valve and come into the circulation, can create complete traffic jam in any of the vessel inside the body. The distal supply will be totally cut off. If we imagine the lower limb, we can understand this is a sudden story. There is no time for the patient to develop any collaterals around the obstruction, so no collaterals seen in acute ischemias. Distal supply gone, so distal part present with severe pain out of proportion to the clinical signs, symptoms, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. First thing to be given in these patients would be low molecular weight heparin, which prevents extension or migration of this thrombus. Then we can do thrombolysis by tissue plasminogen activator, streptokinase, urokinase. If thrombolysis does not help, we can do thrombectomy or embolectomy. AV fistula is an abnormal relation between the artery and vein, most commonly seen after penetrating traumas. Sometimes we as doctors for dialysis make these AV fistulas, and these are called as iatrogenic fistulas. Sometimes these fistulas can occur because of some bacterial, viral, parasitic infections also. Whenever there is an abnormal relation between artery and vein, blood will move from artery to vein. More blood in the vein will become abnormally dilated and tortuous, varicose. The chances of bleeding will be high, chances of skin ulcers would be high. Obviously, the venous return will be more and cardiac output will be more. If we apply pressure over the artery proximal to the fistula, blood supply in the fistula will decrease, venous return will decrease, cardiac output will decrease. Just by putting pressure over the artery proximal to the fistula reverses the changes of AV fistula. This is called as Branham sign or Nicoledoni sign. And the treatment for this is angioembolization or therapeutic embolization. Earlier, we were doing surgical quadruple ligation of these fistulas. Angioembolization is something which we are using very commonly in clinical practice nowadays to control the bleeds, maybe in the upper GI tract, lower GI tract, respiratory tract, or the genitourinary tract. And to seal those bleeding points, we use a coil most commonly. And this coil has got hooks. We can attach this coil with the hooks to the wall of the vessel, which will prevent the migration of coil into the vessel. We can use other substances like human dura mater blood clot and ethyl alcohol sponge as an embolus. Aneurysm is simply abnormal dilatation of an artery, commonly seen in elderly people. As we are growing old, the walls, the strength of the tissues become weaker and weaker. If the wall of the artery is becoming weak and pressure inside is high, it can force the wall of the artery to protrude outside, resulting in aneurysm. A true aneurysm will be having all the three layers, intima, media, and adventitia in the aneurysm, but a false aneurysm will not be having all the layers, maybe just intima is present in the aneurysm. Peripheral aneurysms common in popliteal artery, pseudo or false aneurysms commonly seen in femoral artery due to multiple arterial punctures in the femoral artery. Usually these aneurysms patient remain asymptomatic. If the patient is asymptomatic and the size of the abdominal aortic aneurysm is less than 5.5 centimeter, where the risk of rupture is less, we can just follow up these patients with serial ultrasound and watch whether the aneurysm is increasing in size or not. Sometimes the patient can present with symptoms, maybe mild abdominal discomfort or maybe expansile pulsation because there is aneurysm, so more amount of blood flow would be there, and with each pulsation it would be expanding like this, and the patient may feel those pulsations. If the patient is symptomatic or if the aneurysm is more than 5.5 centimeter in diameter, which can be confirmed on a CT scan, which is the best investigation for an aneurysm, then we have to treat these aneurysms to avoid rupture. And for the treatment, we can simply put a stent, that is EVAR, endovascular aortic aneurysm repair. In the venous disorders, we talked about superficial veins, varicose veins, where first we discussed the venous anatomy in the lower limb. There is a deep venous system like the tibial, popliteal, femoral veins. There is a superficial venous system, great saphenous and the short saphenous veins, and there are connecting veins or the perforating veins between the superficial and deep. The great saphenous vein opens into the femoral vein at the saphenofemoral junction, where there is a saphenofemoral valve. The short saphenous vein opens into the popliteal vein in the popliteal fossa at the saphenopopliteal junction, guarded by a saphenopopliteal valve. Normally, the direction of valve is such that they allow the blood to move from superficial to deep and not the opposite. When the normal person is walking, muscles contracting, pressure in the deep veins increasing, blood in the deep veins is moving upwards, deep veins are getting empty, so superficial veins put their blood into the deep vein and superficial vein also gets empty, so pressure in the superficial vein falls during walking in a normal person. But those individuals who keep on standing for long periods, or maybe anything which is putting pressure on the inferior vena cava or the deep vein, like pregnancy, pelvic tumor, tubo, ovarian mass, deep vein thrombosis, or maybe progesterone causing weakness of the smooth muscles, weakness of the valves, or maybe genetic reasons. If due to high pressure in the deep vein, this pressure damages the valves like saphenofemoral valve. Then the blood will start moving from deep vein into the superficial vein. For example, if the saphenofemoral valve is incompetent and this person is walking, then pressure in the deep vein is increasing, and this high pressure in the deep vein will force the blood of the deep vein to go into the superficial vein. More blood coming into the superficial vein on walking due to valvular incompetence, more pressure in the superficial vein on walking, ambulatory venous hypertension. The great saphenous vein or the short saphenous vein, they make it become dilated, engorged and tortuous, which we call as varicose veins. Patient may present with aching discomfort in the calf or the heel area because of prolonged pooling of blood in the superficial veins, the most dependent part being around the ankle medial malleolus. We may find some changes in the skin like brownish blackish discoloration of the skin, which we call as lipodermatosclerosis, which can even give a champagne bottle or champagne glass appearance because of prolonged pooling of blood around the medial malleolus just beneath the skin. This is going to put pressure on the overlying skin, and the overlying skin can ulcerate, leading to venous ulcer. Most commonly, these venous ulcers are located around the medial malleolus in the gatus area, which is between the medial and the lateral malleolus on the posterior side. These venous ulcers can transform into Marjolin's ulcer. Marjolin's ulcers are also seen in skin ulcers in burn patients, and these Marjolin's ulcer can transform into squamous cell carcinoma, which is a slow-growing cancer, can involve the lymph nodes, treated by surgery. Radiotherapy is not the preferred treatment for these squamous cell carcinomas. We can do a steep classification for these varicose veins. Clinical classification where C1 is reticular veins or telangiectasias, C2 varicose veins, C3 edema, C4 skin changes, C4a eczema, C4b lipodermatosclerosis, C4c coronophlebectasia, C5 and C6 venous ulcer, C5 healed, C6 active venous ulcer. We can do some clinical tests like Brodie-Trendelenburg test, tourniquet test to identify which valve is incompetent. We can do Fagan's test for perforators, Perthes is done in DVT, Adson's is done in cervical rib thoracic outlet syndrome. To confirm our clinical findings in varicose veins, we can do a duplex imaging. If there is a saphenofemoral incompetence on duplex, we can see a Mickey Mouse sign. In the treatment for varicose veins, if the patient has come to us early without any complications, then we advise the patient for some lifestyle modification like avoid prolonged standing, limb elevation at bedtimes, elastic compression stockings. Elastic compression stocking will put pressure on the superficial vein, so they will not allow the blood to remain pooled in the superficial vein, so the chances of complications will be less. But in late stages, if the patient already has developed some complications like lipodermatosclerosis, venous ulcers, then we are left with no option but we have to destroy these varicose veins. We can destroy them by sclerotherapy or by radiofrequency ablation or laser or by surgical removal. For sclerotherapy, various agents have been used like foam, ethanol, phenol almond oil, ethanolamine oleate, sodium tetradecyl sulfate, tetracycline, polidocanol ascarol, picibanil OK432. We can do radiofrequency laser ablation. We can do surgical ablation. In surgery, we do a Trendelenburg operation, which means flush ligation of the great saphenous vein with the femoral vein, and then we do stripping of the great saphenous vein up to the knee level by a Meuse vein stripper. We do not strip the veins below the knee level. If we try to strip the great saphenous vein, most common nerve injured would be saphenous nerve. If we try to strip the short saphenous vein below the knee level, most common nerve injured will be the sural nerve. For perforator incompetence, we are doing SEPS, that is subfacial endoscopic perforator surgery. We can just make a note here. most common nerve injured in removal of great saphenous vein below the knee. It is saphenous nerve. And most common nerve injured in removal of short saphenous vein below the knee, it is the sural nerve. In the deep veins, we talked about deep vein thrombosis. Those individuals who are lying immobilized for long periods may be admitted in ICU for some or the other reason, paraplegia, multiple sclerosis, bedridden, lower limb fractures, or maybe long flights. There will be slowing of the circulation and virtuostriatin pathology, endothelial injury, stasis or turbulence, and hypercoagulability. Stasis of blood will lead to aggregation of platelets and thrombus formation in the deep vein, most commonly seen in the calf vein or the soleal vein. Traffic jam situation, blood is not coming up, blood is getting pooled in the leg itself, and that will be an open invitation for the bacterial party. Signs of acute inflammation, Reuber tumor, Calla dolor, redness, swelling, raised temperature, and pain in the leg area, in the lower leg. Now in these patients, earlier we were doing Homan's test and Moses test. Homan's sign was resistance to dorsiflexion of foot, and Moses was calf pain on squeezing the calf muscle. But since if we manipulate this area, there is a risk that this deep vein thrombus can migrate up and go into the lungs, pulmonary embolism can occur. So these signs have become obsolete and we are not using these signs. Investigation of choice would be duplex imaging, but the best investigation, which is invasive and not used, is ascending venography. We start heparin and then we switch on to oral warfarin for 3 months. That is how we treat the DVT patients. In recurrent cases of DVT, we put a filter into the inferior vena cava so that this deep vein thrombus from the leg cannot go into the lungs and pulmonary embolism does not occur. Lymphedema, it is simply collection of lymph or interstitial fluid. Generally in the lower limbs, more than 4.5 liters of fluid gets collected. Most common type of lymphedema is secondary. Most common cause is filariasis. Most common cause of upper limb lymphedema is post-mastectomy for breast cancer. There can be primary and secondary lymphedema. Primary is probably due to hypoplasia of lymphatic channels. Depending on at what age the patient presents, less than 2 years congenita or Milroy's, 2 to 35 precox or Meeks, more than 35 tarda. Out of these three, congenita, precox and tarda, precox is more common. However, most common lymphedema is secondary. Filariasis, Eastern UP, Bihar, or may be related to some cancers causing involvement of the lymph nodes, surgical removal of the lymph nodes, radiotherapy destruction of the lymph nodes. Chronic lymphedemas can even lead to filariasis. The treatment for lymphedemas is simply manual massaging and pneumatic compression devices. The results of surgery are extremely poor, like nodovenous shunts. Right. Now, let us revise the entire vascular surgery without looking at the workbook. And let us just close our eyes and try to revise this without the workbook. Right, beta. So, in vascular surgery, we talked about arterial, venous, and lymphatic disorders. In arteries, we talked about gradual arterial obstruction, sudden arterial obstruction, AV fistula, aneurysm. Venous disorders, superficial veins, varicose veins, deep vein thrombosis, lymphatic disorders, lymphedema. In arterial disorders, gradual arterial obstruction. The commonest cause of gradual arterial obstruction is atherosclerosis. Burgess disease, thromboangiitis obliterans can also cause these arterial obstructions. If we just try to imagine that atherosclerosis is developing in the intima of the femoral artery, in the initial stages, because of this plaque in the femoral artery, the lumen may not be narrowed much and patient may not be having any ischemic symptoms or signs, especially at rest. But when the patient is exercising, like when the patient is walking, the maximum demand in the lower limb would be by the calf muscles, and then the patient may start experiencing calf pain on walking. This is what we call as intermittent claudication. The distance which the patient is able to walk without pain is claudication distance. Usually we talk about lower limbs. Sometimes we see that in the upper limbs when we have to write at a very fast pace and the oxygen supply is not proper, then we call it as writer's spasm. We can grade this intermittent claudication. Boyd 1, calf pain on walking, which improves with further walking due to washout of substance P. Boyd 2, calf pain on walking, but patient continue to walk with pain. Boyd 3, calf pain on walking, now he cannot walk any further and has to take rest. Boyd 4, when the patient experiences pain at rest, rest pain. Rest pain, if the atherosclerotic plaque increases and the lumen decreases, the supply to the distal part is decreasing. Now the supply has decreased to such an extent that even at rest the patient is having pain. And the most distal part is going to suffer the most. So rest pain is something which is felt in the foot at rest. Gradually, if the obstruction increases further, the distal part, that is the foot, will become cold, numb and paresthesias. Pregangrene, gangrene can occur. As a doctor, when we see these patients, we examine the pulses, like in the lower limb, femoral, popliteal, anterior and posterior tibial and dorsalis pedis, femoral 2 cm below the mid-inguinal point, popliteal, most difficult to feel because there is no bony prominence and it is deep. Anterior tibial next to tendon of extensor hallucis longus, posterior tibial between the posterior border of medial malleolus and Achilles tendon at inversion of foot, dorsalis pedis in the proximal half of first metatarsal space. Distal to the obstruction, the pulse will be low volume, feeble or absent. Proximal to the obstruction, the pulse will be high volume. Sometimes, if the patient has developed collaterals around the obstruction and patient comes to you with ischemic symptoms, there is a possibility on initial examination, because the blood is coming to the distal part through the collaterals, the distal pulses may appear normal. In such cases, you ask the patient to walk in the hospital corridor, do the exercise, and maybe because of increased demand, these small collaterals are not able to bring the blood sufficiently, and then the distal pulses will disappear. Again, you ask the patient to take rest, again the distal pulses will reappear. This disappearing pulse is because of collaterals. If you do the auscultation and you hear a whoosh type of sound, it simply indicates turbulence. Probably there is distal stenosis or obstruction. We can also measure ankle brachial pressure index, that is systolic pressure at the ankle, and compare it with the systolic pressure at the arm. If the story is normal, the ratio may be 1.1 plus minus 0.2, but depending on the severity of traffic jam in the femoral artery, the distal supply will also decrease accordingly and the pressure at the ankle will also decrease accordingly. If this ratio is less than 0.9, suggest intermittent claudication, less than 0.5 rest pain, 0.3 critical limb ischemia, 0.1 gangrene. By this we make a clinical diagnosis about the severity of arterial obstruction. We can do a Fontaine's classification as well. Fontaine 1, no symptoms. 2, intermittent claudication. 3, rest pain. And 4, gangrene. 2, intermittent claudication can be divided into 2A and 2B, mild and moderate. We can confirm our clinical findings by color Doppler, which is the investigation of choice. Angiography is not preferred because it is invasive. Once the diagnosis is made, we want to relieve the patient's symptoms, and this can be done if you are able to increase the supply to the distal part. For this, we have got 4 options: lifestyle modification, medicines, angioplasty, surgery. In lifestyle modification, we ask the patient to quit smoking, reduce weight, brisk walk 40 minutes in the morning, 40 minutes in the evening, and dietary modification. If the patient is able to follow our advice, there is spontaneous improvement in 6 months' time due to development of good collaterals around the obstruction. But patients usually can't afford this expensive treatment of quitting smoking, so we have to look for other options like medicines, vasodilators like cilostazol, oxypentyphylline, antiplatelets for short-term clopidogrel, long-term aspirin, and statins. We can do PTA, percutaneous transluminal angioplasty by a Fogarty catheter balloon angioplasty. We can place the stent inside, metallic or drug-coated. Drug-coated stents are better, sirolimus-coated, which do not allow the aggregation of platelets. We can also do surgery where we can put a bypass graft around the obstruction. This graft can be taken from inside the body, or it can be bought from the market. From inside the body, autologous; from the market, synthetic. Autologous graft, arterial venous grafts. Artery is more strong, so arterial graft will give us long-term patency. We use internal memory artery commonly, left or right. We can use gastroepiploic artery. We can even use great saphenous vein. Synthetic grafts can be textile, non-textile. Textile, Dacron, can be woven or knitted. Woven are better, and textile Dacron is better than non-textile PTFE, polytetrafluoroethylene. Whenever we are doing this bypass graft surgery, there can be early graft failure due to faulty technique by the surgeon. Late graft failure is due to graft occlusion. Graft infection is because of Staph aureus. For suprainguinal aortoiliac obstructions, we prefer using a Dacron graft. For inguinal iliofemoral obstruction, we prefer doing an angioplasty. For infrainguinal femoropopliteal bypass, we prefer using great saphenous vein. Most common peripheral bypass surgery done is a femoropopliteal bypass. Sometimes, like in Burgess disease patient where we cannot opt for any angioplasty or bypass surgeries, and patient keeps on coming to us with rest pain, we can do a lumbar sympathectomy where we make an incision in the abdomen in the lumbar region and remove the lumbar sympathetic chain L1, L2, L3, L4. By doing a lumbar sympathectomy, the arterioles in the foot get dilated and they steal blood from the calf. So calf blood migrates towards the foot, more blood in the foot. Foot pain, rest pain is relieved. But if the patient had calf pain, then blood in the calf has decreased, so calf pain will increase, intermittent claudication will increase. So we don't do lumbar sympathectomy in intermittent claudication. If the patient has developed gangrene, then we have to do amputation. Burgess disease is thrombosis and thrombophlebitis of small to medium-sized vessels associated with Raynaud syndrome, seen only in those people who use tobacco, either they smoke or they eat. 95% are males, usually less than 45 years of age, preferably less than 30 years of age, commonly involve the lower limbs. Burgess can involve the artery, vein and nerves, but does not involve the lymphatics. Patients come to us with rest pain usually. Wohlen's criteria can be used to make the diagnosis, and in the treatment for rest pain, we advise the patient for lifestyle modifications, cigarettes or legs. We can give some medicines and we can do lumbar sympathectomy. Interesting disease, Raynaud's disease. This is a spasm of the arterioles on cold exposure. probably due to some hypersensitivity commonly seen in young females in the upper limbs. Since it is a disease of the arterioles, so arteries are normal, pulses are normal. Primary Raynaud's, secondary Raynaud's. Primary when it is not associated with any other disease, and secondary when it is associated with some other disease, maybe SLE, rheumatoid arthritis, scleroderma, thoracic outlet syndrome, cervical rib. As soon as we ask this lady to dip her fingers in cold water, there is a spasm of the arterioles and it becomes white. Stagnation of blood makes this pulp space blue, and when the lady warms her hands, the arterioles dilate again and the blood reappears and it becomes red. This characteristic sequence of color changes white to red is called as Raynaud's phenomena. In the treatment, we advise lifestyle modification, avoid any cold exposure, wear warm clothing or gloves. We can give medicines like calcium channel blockers and nitrates, and rarely cervical sympathectomy can be done. Sudden arterial obstruction or acute limb ischemia is a sudden obstruction of a vessel by a substance which is foreign to the bloodstream. This is something sudden. Most common source is the mural thrombi from the heart, and this can create complete traffic jam in any of the vessel inside the body. Since it is sudden, there is no time for the formation of collaterals, so no collaterals are seen in acute limb ischemia. Because there is a sudden complete traffic jam situation in the vessel, and suppose we are talking about this sudden obstruction in the popliteal artery, that means there is no blood going into the tibial and the dorsalis pedis, no blood going towards the ankle or the foot. The distal part, that is the ankle foot area, the patient will have severe pain which will be out of proportion to the clinical symptoms, clinical signs. There will be pallor of the foot, there will be pulselessness, tibial pulsations and dorsalis pedis will be absent. Nerves are not getting any blood supply, so we'll find paresthesias, paralysis, and this foot will become cold, poikilothermia. This is a vascular emergency, and we know that if we don't remove this embolus, if we don't dissolve this embolus, no supply to the distal part will become gangrene, and then we'll have to do amputation. We don't want this patient to lose the limb. So immediately we start the low molecular weight heparin, which prevent the migration or extension of this thrombus, and then we give thrombolytics like tissue plasminogen activator, streptokinase and urokinase. If this does not help, we can pass a Fogarty catheter and remove this thrombus or embolus, that is thrombectomy or embolectomy. Arteriovenous fistula. This is an abnormal relationship between the artery and the vein, most commonly seen due to penetrating traumas. Surgeons do make these AV fistulas for dialysis purpose. These are iatrogenic fistulas. Sometimes these AV fistulas occur because of infections, maybe bacterial, viral or parasitic. If abnormal relation is developed between artery and vein, artery is having high pressure, so blood will move from artery to vein. More blood coming into the vein will get abnormally dilated and tortuous. More venous return, more cardiac output. If we apply pressure over the artery proximal to the fistula, the blood flow in the fistula will decrease, venous return will decrease, cardiac output will decrease. Just by putting pressure over the artery proximal to the fistula reverses the changes of AV fistula. This is called as Branham's or Nicoledoni's sign. In the treatment, we can simply put an embolus in the fistula, that is angioembolization or therapeutic embolization. Angioembolization, therapeutic embolization is being routinely done nowadays to control the upper GI, lower GI bleeds, respiratory tract bleeds, genitourinary tract bleeds. For that, we use coil as the commonest substance, though other substances like human duramatter, blood clot, ethyl alcohol sponges can be used. Earlier, for AV fistulas, we were doing quadruple ligation, surgical ligation, but now we are doing angioembolization. Aneurysm is simply abnormal dilatation of an artery, commonly seen in elderly people. As we are growing old, the tissues become weaker and weaker, the strength become weaker and weaker, and if the wall of the artery has become weak and pressure inside is more, high pressure can force this weak wall to protrude outside and lead to aneurysm. True aneurysms, which have got all the layers of the artery in the aneurysm, intima, media and adventitia. False or pseudo aneurysms, where all the layers are not present, maybe just intima is present in the aneurysm. Peripheral aneurysms, commonly seen in popliteal artery. Pseudoaneurysms, commonly seen in femoral artery, because we do multiple arterial punctures for arterial blood gas analysis in the femoral artery. If we talk about abdominal aortic aneurysms, usually the patients are asymptomatic. If the size of the aneurysm is less than 5.5 centimeter and no symptoms to the patient, no active intervention is required. We just keep on following these patients with serial ultrasounds. However, if the patient is having any symptoms like abdominal discomfort or pain, or expensile pulsations are being felt by the patient in the abdomen, or if the size of the abdominal aortic aneurysm is more than 5.5 centimeter, which can be confirmed by CT scan, then the risk of rupture is high, and we should treat these patients by EVAR, endovascular aortic aneurysm repair. Venous disorders, superficial veins, varicose veins. In the venous anatomy of the lower limb, there is a deep venous system, tibial, popliteal and femoral veins. Superficial venous system, great saphenous vein and short saphenous vein. Perforating veins, connecting veins between the superficial and deep. Great saphenous vein opens into the femoral vein just beneath the groin crease at the saphenofemoral junction, guarded by a saphenofemoral valve. Short saphenous vein on the lateral side that opens into the popliteal vein in the popliteal fossa at the saphenopopliteal junction, guarded by the saphenopopliteal valve. In normal individuals, valves which are present in the vein, they allow the blood to move upwards. Valve allow the blood to move from superficial veins into the deep veins, but not in the opposite direction. When a normal person is walking, muscles of the lower limb contracting, pressure in the deep vein increasing, and this pressure in the deep vein forces the blood to move up towards the heart. This blood does not go into the superficial vein because of the presence of valves. But in those individuals who keep on standing for long periods, like traffic policemen, rickshaw pullers, or there is any traffic jam situation in the deep vein, maybe pregnancy, the fetus pressing on the inferior vena cava, maybe a tumor in the pelvis pressing on the inferior vena cava, or a tubo-ovarian mass, maybe a thrombus in the deep vein, then blood from the deep vein will not be moving up towards the heart properly. Pooling of blood in the deep vein, more pressure in the deep vein, and this more pressure will put pressure on the valves like saphenofemoral valve, and if saphenofemoral valve becomes incompetent or saphenofemoral valve gets damaged, then blood from the deep vein will come into the superficial vein, that is from the femoral into the great saphenous vein. More blood coming into the great saphenous vein, it will become abnormally dilated and tortuous, which we call as varicose veins. If the valve has become incompetent, and when this patient is walking, muscles contracting, pressure in the deep vein increasing, blood from the deep vein comes into the superficial vein, more pressure in the superficial vein on walking due to valvular incompetence, this is called as ambulatory venous hypertension. Patients will present with aching discomfort in the calf or the heel area. Sometimes complications can occur because of pooling of blood around the ankle area. There may be brownish blackish discoloration, leathery appearance of the skin, which is lipodermatosclerosis. Pooling of blood around the medial malleolus just beneath the skin will put pressure on the skin, and the skin can ulcerate, resulting in ulcer. Venous ulcer, most commonly seen around the medial malleolus. in the gatus area, that is area between the medial and the lateral malleolus posterior side. This venous ulcer can transform into Marjolin ulcer. Marjolin ulcer can be seen in skin ulcers in burn patients. Marjolin ulcer can transform into squamous cell carcinoma, which is a slow-growing cancer, can lead to involvement of lymph nodes. Surgery is the treatment of choice. Radiotherapy is not the treatment of choice for these squamous cell carcinomas. To diagnose these varicose veins, we can do some clinical tests like Brodie-Trendelenburg test or Tunicke test. We can do Fagan's test for perforators, Perthes is done for DVT, Edson's for cervical rib. We can confirm our clinical findings by duplex imaging, where if there is saphenofemoral incompetence, we can see a Mickey Mouse sign. In the treatment, in early stages of varicose veins, when there are no complications, we advise lifestyle modification, avoid prolonged standing, limb elevation, especially when the patient is lying down on the bed, elastic compression stockings which will put pressure from outside so blood will not remain pooled in the superficial veins, chances of complications will be less. But in late stages of varicose veins, if the patient already has developed complications like lipodermatosclerosis or venous ulcers, then we are left with no option but to remove or destroy this varicose vein. To destroy the varicose vein, we have the options like sclerotherapy, radiofrequency laser ablation, and surgical removal. In sclerotherapy, we can use foam, phenolin almond oil, ethanolamine oleate, sodium tetradecyl sulfate, tetracycline, polidocanol escarole, picibanil OK432. We can do radiofrequency laser ablation, which is being commonly done nowadays. We can do surgical operations where we do Trendelenburg operation, which is flush ligation of the great saphenous vein with the femoral vein, and then we do stripping of the great saphenous vein. We do not strip the great saphenous vein below the level of knee to avoid injury to saphenous nerve. Same thing if we are doing surgery for short saphenous vein, we do not strip the short saphenous vein because of risk of injury to the sural nerve. If there are perforator incompetence, then we are doing SEPS. This is subfacial endoscopic perforator surgery. For deep veins, we talk about deep vein thrombosis, usually seen in those individuals who keep on lying for long periods, prolonged immobilization like ICU patients, maybe paraplegia, multiple sclerosis, lower limb fractures, bedridden patients, long flights. Now, because of lying for long periods, there is slowing of the circulation and virtuous triad in pathology, endothelial injury, stasis or turbulence, and hypercoagulability. If there is stasis of blood, the chances of aggregation of platelets would be high, thrombus formation would be high, and this is how the deep vein thrombus can form, most commonly in the calf vein or the soleal vein. Because there is a traffic jam in the deep vein, the blood will not be able to move upwards. There will be pooling of blood down, and this will be an open invitation for the bacterial party, acute inflammation, cardinal signs of acute inflammation, ruber-tumor calor dolor. The patient will have redness, swelling of the lower leg. In this, earlier we used to elicit Homans and Moses sign, where Homans was resistance to dorsiflexion of foot by the calf muscles, and Moses was calf pain on squeezing the calf muscle. They are not done nowadays because any manipulation in this area can lead to deep vein thrombus migrating up, and it can go into the heart and lungs and lead to pulmonary embolism. What we do is duplex imaging. This is the investigation of choice. Best investigation is an invasive investigation which is not done, that is ascending venography. That is the gold standard investigation. In the treatment for these DVTs, we give heparin and then warfarin for 3 months. In recurrent DVTs, we can apply filter in the inferior vena cava. Lymphatic disorders, lymphedema, it is simply collection of lymph or interstitial fluid in the interstitial space. Usually in the lower limbs, more than 4.5 liters of lymph gets collected. Most common lymphedema is secondary, filariasis, Eastern UP and Bihar. Most common cause of upper limb lymphedema is post-mastectomy for breast cancer. Lymphedemas can be classified as primary and secondary. Primary, when it is due to hypoplasia of lymphatic channels. Secondary, when it is due to some diseases like filariasis or maybe cancers or surgical removal or radiotherapy destruction of lymph nodes. Primary lymphedema can be congenita, precox or tarda. If the patient presents below 2 years of age, it is congenita, 2 to 35 years precox, more than 35 years tarda. Congenita also called as Milroy's, precox also called as Meeks. Out of congenita, precox and tarda, it is the precox which is more common, but overall the commonest lymphedema is secondary lymphedema, where the commonest cause is filariasis, but specifically for the upper limb, it is post-mastectomy for breast cancer. In chronic lymphedemas, we can find elephantiasis type of situations. The treatment for lymphedema is just manual massaging, manual lymphatic massaging or manual bandagings can be done. Pneumatic compression devices can be used. The results of surgery like notovenous shunt are extremely poor. Thank you very much for your patience, Vita. So this is the complete revision of your vascular surgery. Now, we'll take a break here. Just relax yourself. See you later. Bye-bye.